Good afternoon, dear students. So here I am with the recall of FMGE July 2024. Now, before I proceed, let me explain what I am planning to do here. So the very first thing is that I'll be taking all the 300 questions, whatever has been collected till now, and I just want to convey to you that see, these are not the exact questions which came in the exam, right? So these are recall as per the students, and we have tried to compile the question in whatever best possible way. So the question won't be the exact which was asked in the exam, right? So that is one thing. And secondly, what I want to discuss with all of you is especially the topics, what you commonly say, previous year topics, right? So the basic purpose of this session is to just give you an idea like what topics were important, and the questions were framed from which topics, number one. And number two, like if there are clinical questions or image based questions, what all tricks you must know to solve them, right? So the basic purpose of this session is to just give you an idea about like what are the important topics. Secondly, if you have a clinical question which seems very lengthy or which seems very complicated, what should be your approach, how you should approach toward that particular question, and how you can reach up to the answer closely, to the closest possible answer, right? So that is what is the purpose of this session. Now, as I said previously, that word to word recall can't be possible because the few questions are extremely tough, and it is difficult to get the exact word to word framing of the question, right? So but more or less we have tried to get to the most possible type of question framing, and I am very hopeful that you will enjoy the session, right? So without any further delay, we can start the session, and I'll be taking all the 300 questions in a span of 2 days. So I'll try to take nearly 150 questions today, and I have kept 150 questions for tomorrow's session, right? So today I'll be focusing more on the MCQs from anatomy, medicine, surgery, ops, gynae, and PSM, right? So we can start with the anatomy part. And there was a clinical question which was like a person was climbing upstairs, going upstairs, and suddenly fell down, and there is piercing over the posterior triangle of a neck. So an iron nail, it pierced into the posterior triangle of the neck, and post injury the patient was not able to elevate the shoulder, or what you can say, loss of shrugging, right? So this movement is shrugging. So post injury, on the affected side, the patient was not able to shrug the shoulder. So which structure is most likely injured? Now here you can get up to the answer in 2-3 ways. Number one, if you know that, see, there is injury in the posterior triangle of the neck, right? So one thing is that if you know that which nerve passes through the posterior triangle of neck, then you can get up to the answer, right? So here the nerve is spinal accessory nerve. Okay, so this is one way of reaching up to the answer. Now suppose if you don't know this particular thing, then you can take the clinical presentation, right? So what is the presentation here? There is loss of shrugging, right, of shoulder. So the patient cannot shrug. Now you must know what muscle is responsible for this particular action, and the muscle which is responsible for this particular action is trapezius, right? And if you know the nerve supply of trapezius, still you can reach up to the answer. So there are two ways in which you can reach up to the answer. Either you know the exact anatomy or in terms of the posterior triangle of the neck, or you can evaluate the symptomatology and then you can reach up to the answer. So this way you can reach up to the answer, and the nerve involved is the spinal. So this is the spinal accessory nerve which supplies the trapezius, and since the nerve is paralyzed, so trapezius will be paralyzed and patient will find very difficult difficulty in shrugging the shoulders, right? So see, you have two ways to reach up to the answer. And just to take a little bit of anatomy of the posterior triangle of the neck. So anteriorly, you can see here, this is sternocleidomastoid muscle, right? So this is the sternocleidomastoid muscle, right? So this is, you can see, going all up to the mastoid process. Posteriorly, if you see, this is the trapezius muscle. Okay, so this is the trapezius muscle. Okay, and in between and lower down, this is all clavicle. Okay, so this is clavicle. So you can see a triangular area, and this triangular area is known as posterior triangle of neck, and through this area there is passage of the spinal accessory nerve. So this is spinal accessory nerve, right? And this spinal accessory nerve is going to supply the trapezius muscle, right? So therefore, if there is any penetrating injury or any incisional injury in the posterior triangle of the neck which might injure the spinal accessory nerve, then there would be paralysis of trapezius. And also there is one more muscle which is supplied by spinal accessory nerve, and that is sternocleidomastoid. Clear? So these are the two muscles which are supplied by spinal accessory nerve, right? And in particular reference to the question with loss of shrugging, we will say that the muscle which is paralyzed is trapezius, right? So this is how you can reach up to the answer for this particular question. Now moving on to the next question. Now this is again a repeated question. It has been asked a couple of times before, and an image was given, and some gentleman or a doctor was palpating some artery. Now this area here, this is medial malleolus. Clear? So this is the medial malleolus, and this area, this tendon is tendoachilles, right? So this is the tendoachilles, and in between these two there passes the posterior tibial artery, right? So here this is all territory of the posterior tibial artery. Clear? So this is the posterior tibial artery. So the palpation of the posterior tibial artery is done behind the medial malleolus, and particularly in between the medial malleolus and the tendoachilles, especially when the foot is inverted. So that gives more prominent space for palpation. So this is the palpation of posterior tibial artery. Clear? So this is the posterior tibial artery. Now moving forward to the next question, and here a image was given. This is the section of the transverse section of the brain, and it was asked like, what is this green structure, right? So I think this is again a very important topic, and this question has been asked many number of times. Many times CT scan has been given or MRI has been given, and then they have labeled the structure for identification, but here it is an image. So let us discuss the structures first. Now this area, this is the putamen. Okay, this is putamen. Clear? Deep to putamen you have globus pallidus. So this is globus pallidus, and again globus pallidus has two parts, globus pallidus externa, and deep to globus pallidus externa will be globus pallidus interna. Okay, so this is globus pallidus interna, right? So this is the globus pallidus interna. Many times you might have heard the word lenticular nucleus. Now, if you take all these terms together, it is known as lenticular nucleus. Now, these are all parts of basal ganglion, right? So, these are components of basal ganglion. Clear? Now, then coming more medially, you have this internal capsule. Okay, so this is the internal capsule, which you can see in green color, and if you look properly, the angle is towards the lateral side. So it is just like a V, and the angle is towards the lateral side. If you come even more medial, you will find this is the caudate nucleus. So this is the caudate nucleus. Okay, so this is, you can see, and even more medial most you will find the thalamus. So here will be thalamus. Okay, so this is very important, and many times it has been asked, and I am very sure most of you must have marked it right, that this is the internal capsule. Clear? So this is internal capsule. Now, next question was about the anatomy or the normal constrictions in the esophagus, and a question was like during endoscopy, when the doctor was pushing the endoscope down the esophagus, he felt that there was some resistance which was about 25 centimeter from the central incisor. Now, this resistance is because of the constriction which is offered by the arch of aorta, right? So at 25 centimeter, there is constriction in the esophagus, and that is because of arch of aorta, right? So, and this is very important for everyone to memorize the constrictions of esophagus. These are the normal constrictions, and they are produced because of pressure from some external nearby structure. One of the narrowest portion is the cricopharynx, and we usually say that that is the starting point of esophagus, so that at the level of the cricoid cartilage. So if you know the length of esophagus length is 25 centimeter, right? And therefore, if you measure it from the central incisors, you have to add 15, and from central incisor, the total length till the gastroesophageal junction comes out to be 40 centimeters, right? So the cricoesophageal junction is at the distance of 15 centimeter from the central incisors. Then add 10 more centimeters, it is arch of aorta. Then 3 centimeter more, that is the left pulmonary, left main bronchus, and 40 centimeter is the point of entrance of the esophagus through the diaphragm. So these are the constrictions in the normal esophagus, and this constriction actually are important clinically in two terms. Number one, if there is some ingestion of the foreign body, it can get halted at these constrictions, or if someone is doing any intervention like esophagoscopy or endoscopy, he have to be very careful at these landmarks, because he might felt resistance, or especially if he is doing rigid esophagoscopy, there are chances of even perforation. So one should know the normal distance of these esophageal constrictions from the central incisors, right? So 15, 25, 28 and 40, and the distance of the cricopharyngeal junction, which is the starting point of esophagus, is 15 centimeters from the central incisors. And since esophagus is 25, therefore if we talk about the point of entrance of the esophagus through the diaphragm, it will come out to be 40 centimeter, right? So please remember this, and this was pretty easy question, repeated many number of times, like 25 centimeter from central incisors, the compression of arch of aorta leads to the constriction in the esophagus, right? So this is one question. Now, next question. Here a transverse section of the abdomen was given, and again, see, for most of the questions we don't have the exact images which was given in the exam, but yes, for discussion purpose we have taken somewhat more relatable image which can just help us in getting the stem of the question, or getting to know what actually was asked in the exam, right? So this is one more question, and here it was asked like what is this structure for, right? So it was asked like what is this structure for here. So this is what. Now before that we can discuss what we are able to see in this particular figure. So first thing we can see that this is the spleen, okay? This is the spleen. Then here this is stomach, this is liver, this is the left kidney, and this is the right kidney. Clear? So these are the organs which you can see. Now what happens from spleen? There are some ligaments which span across the nearer organs. So one of the ligament is between the spleen and the stomach, okay, and there is one more ligament which spans between the spleen and the left kidney, right? So this spleen, this ligament is actually the one which is extending from the spleen to the left kidney, and this one is the ligament which is spanning across ligament. Perfect. So the answer to this question is lino-renal ligament. So please note that the word lino actually means spleen. Clear? So this is how you can remember quite easily. Just looking at the things, you can very well make it out that what ligament is this actually. Okay, so this is one thing. Now here you can see, I just want to show you some more important things. One is the lesser sac, then another is the greater sac, and in between the two we have the foramen of Winslow, which is also known as the epiploic foramen. Clear? So foramen of Winslow or epiploic foramen. So it is actually a communication between the lesser sac and the greater sac. Now let us see where is the lesser sac. So this all area is the lesser sac. Okay. So this all area is lesser sac, and whatever the structure, so this is all lesser sac. Now whatever the all area you are seeing in the pink color, this is all greater sac. Okay, so this is all greater sac. Whatever in the pink, that is all greater sac. Okay, so this is the greater sac, and the connection between the lesser sac and the greater sac, if I write it, this is the greater sac, and the connection between the lesser sac and the greater sac is, this is the connection, right? So this is known as epiploic foramen. Okay, so this is the epiploic foramen or the foramen of Winslow. So just note down all these features. The gastrosplenic ligament, okay, so this is gastrosplenic ligament, then lino-renal ligament, which is the ligament extending from the spleen till the left kidney, and then lesser sac, epiploic foramen, and then greater sac. Right, so this is very important and it has been asked many number of times. Okay, so this is one important question. Then moving forward to the next question, and here we can see some clinical test was done, and then it was asked like what movement are we checking in this particular question, right? So if you look at the image, you will appreciate that the patient is lifting one of his lower limb off the ground, right? So he is lifting it off the ground, and then some measurement or some evaluation has been done with respect to these lines. Okay, so you can see a almost horizontal, and then you can see a slightly tilted line. So if you observe all these things, you will find that what is actually being carried out here is the Trendelenburg test, right? So Trendelenburg test has been done, and what actually we do in Trendelenburg test, we check the abductor mechanism at hip, right? So what we are checking the abductor mechanism. So answer would be abduction, one thing. Now what is this abductor mechanism? It means we are checking the abductor muscles of the hip joint. And what are the abductor muscles? These are gluteus medius and gluteus minimus. Clear? So what muscles we are checking? Gluteus medius and gluteus minimus. Now what is the nerve supply of these muscles? These both muscles are supplied by superior gluteal nerve, right? So this is what we are actually looking in this particular test in terms of hip movements, especially the abductor mechanism. So the answer is abduction. Now we can just have a look at what actually this test is and how we interpret it. So firstly, what we do, now we have to see what is the level of anterior superior iliac spine on both the sides. So the landmark what we observe is the anterior superior iliac spine. Clear? On both sides we will see that. Now what happens when we are, or any subject is standing on both the legs, the pelvis is something like this. So it means the ASIs of this side and ASIs of this other side, they are at the same level. Now what will happen? Suppose if you tell the subject to stand on one leg and take off the other leg off the ground, right? So the moment the patient takes off the other leg or the other lower limb off the ground, because of the pull of gravity, there is a tendency for the pelvis to sag, right? So what can happen? The pelvis might become something like this, right? So this is the ASIS and this is the ASIS. So this is the tendency. Now what happens? The abductor mechanism. This is the abductor mechanism of this supported side. It will contract and it will move the pelvis in such a manner so that the unsupported side ASIS comes upward, and therefore the effective position of both the ASIS remains at the same level, right? So there is no dipping of ASIS of the unsupported side if the abductor mechanism is okay. If it is working fine, you will see both the ASIS are at the same level despite one limb is off the ground, right? So this is the normal mechanism, and this makes sure that there is no sagging or no dipping of the anterior superior iliac spine even if the lower limb is off the ground, right? So this is the normal mechanism. So if I show you it in this diagram, now this is the supported side, right? So this is, say, the right lower limb, and as soon as the patient takes off the left lower limb off the ground, the right side muscles, they pull the pelvis of this side down so that the opposite side pelvis goes upward and both the iliac spine comes to lie now at the same level, right? So both the iliac spine will be at the same level. Okay, so in this image it has been shown from behind, but actually we see it from front because ASI is on the front, right? So this is just for demonstration purpose, and usually we observe the patient from the front, right? So this is what normally should happen if the abductor mechanism is intact. Now suppose if these muscles are paralyzed, so what will happen? These muscles, right? So if these muscles are paralyzed, it's better I will say show on this side. So if it is paralyzed, what will happen? It will not be able to pull the pelvis down on the supported side, right? So this is the supported side, right? So it will not pull the pelvis down on the supported side, and therefore the pelvis on the unsupported side will sag down, right? So now if you observe the anterior superior iliac spine, it will be somewhere here in this and it will be somewhere here in this. So you can see the line has now tilted. So this is a positive Trendelenburg sign, which is showing that the abductor mechanism is not intact. Now in terms of this particular question, I am just mentioning the muscles, although in Trendelenburg we also check the integrity of the hip joint, the neck of femur as well. So the other causes of a positive Trendelenburg test, if there is fracture neck of femur, or if there is dislocation of hip joint. Clear? So these are a couple of more entities where we find a positive Trendelenburg test, because only muscle contraction won't work. There has to be a liver, there has to be a fulcrum, a functioning unit as such, right? So if there is any problem in the neck of femur, right? So this is the neck of femur region, or if there is any problem within the hip joint, right? So this is the hip joint. Clear? So this is the hip joint. So three things are needed for a negative Trendelenburg test. First is muscles, second is the hip joint, and third is the neck of femur. Clear? Anyway, but in relation to the question, it was about, since it was about the abductor mechanism, so the answer would be abduction. Clear? So this is the Trendelenburg test, and again a very important topic. All of you should know this thoroughly and properly. Now next question. Now this question has been repeated after many years, and this was about like from the 6th pharyngeal arch artery on the left side, right? So on the left side, 6th pharyngeal arch artery gave rise to what structure? Now here there are two things. On the right side there is only one structure, but on the left side from the 6th pharyngeal arch artery there are two structures, right? So if you remember fetal physiology, there is a communication between the pulmonary trunk and the descending aorta, which actually bypasses all the blood from the right side of the heart directly into the aorta, and that is the ductus arteriosus, right? So that ductus arteriosus is actually developing from the 6th pharyngeal arch artery on the left side, right? So because the ductus arteriosus is present on the left side only, so this is one structure which is developing from the 6th pharyngeal arch artery, specifically on the left side. If there is no mention of the side, then you will have pulmonary artery. So on either side there is development of pulmonary artery, right? So if I show you in the image, so this is the right pulmonary artery. Okay, so this one is the right pulmonary artery. Clear? So again, this is, if the question is about the derivative of sixth pharyngeal arch artery on right side, then your answer would be right pulmonary artery. And on the left side, we have two derivatives. One is, of course, the left pulmonary artery. Clear? So one is, of course, the left pulmonary artery, but along with this, there is also the ductus arteriosus. So if you this is the ductus arteriosus. Clear? So these two structures are on the left side, right? So left pulmonary artery and ductus arteriosus, and these are all from the sixth pharyngeal arch artery. Clear? So I have just taken especially for the sixth pharyngeal arch artery. Pulmonary artery are on the either side, but specifically on the left side, we have an additional derivative, that is ductus arteriosus, right? So the answer is ductus arteriosus. Okay, so sixth pharyngeal arch artery. Now there is one more important question again from the facial nerve injury, and many times we have question from facial nerve, either in one way or clinical presentation point of thing. So here there is a clinical presentation. So some operative procedure was done on the ear, and accidentally the surgeon damaged a nerve. Now on examination, patient developed leg of Thyroid. Now which nerve could have been injured? Now here one should know the meaning of leg of Thyroid, right? And which nerve injury can lead to leg of Thyroid. So if you look at the image, I think you can understand this is normal, okay, and this is the injured side. So if you tell the patient to close the eyes, you can see on the normal side he can close the palpebral aperture very nicely, but on the affected side the eyes cannot be closed completely. So this is leg of Thyroid, and this suggests that there is injury to facial nerve. I think all of you must have read it many times in Bell's palsies, right? So this is, or Ramsay-Hunt syndrome even. So this is typical leg of Thyroid, which is a classical feature of seventh or facial nerve injury. Clear? So this is leg of Thyroid, and especially related to ear, this is facial nerve injury. Okay. Now next question, it's a very straightforward question, and again a repeated question. What type of joint is between epiphysis and diaphysis of a long bone? Now here we see a type of cartilaginous joint. Now this is a cartilaginous joint, right, between the diaphysis and the epiphysis, and this is actually the growth plate, what in simpler terms if you say. And we have two type of cartilaginous, one is primary and another is secondary. Now in primary, this is mainly composed of hyaline cartilage, but the secondary has a rim of fibrocartilage as well. So fibrocartilage surrounding the hyaline cartilage. Then one important feature is that usually these are midline, right? And if we take examples, of course this is joint between epiphysis and diaphysis, and example of secondary cartilaginous, you can remember pubic symphysis or intervertebral disc. Clear? So you can see that both of these joints, they are in the midline of the body, right? So this is in short. And so the answer for this particular MCQ comes out to be synchondrosis, right? So this is known as synchondrosis, and this is known as symphysis, right? So this is symphysis. Clear? So the answer would be synchondrosis. Now, just in short, what we have already discussed in synchondrosis, which are actually the primary cartilaginous, this is principally composed of hyaline cartilage, but the secondary cartilaginous, which is symphysis, it has a rim of fibrocartilage around the hyaline cartilage, right? So if you can see, if you say this is the hyaline cartilage, okay, so this is, you say this is the hyaline cartilage, then there is a rim of fibrocartilage, something like this. So this is the fibrocartilage. So this is the symphysis, or what we say secondary cartilaginous, right? And the synchondrosis which we are actually discussing is actually present over the diaphysis and epiphyseal junction, and symphysis, which is secondary cartilaginous, it is in the midline, especially the pubic symphysis and intervertebral disc, right? So this is in the basic difference, and I, as I told you already, these are present in the midline of the body. So primary cartilaginous, secondary cartilaginous. Now, epithelium lining of trachea. I think this is again a very basic and a repeated question, and here the answer is ciliated pseudostratified columnar. Now here I think one term is ciliated, another is columnar, okay, and third is pseudostratified. Now ciliated means there is presence of cilia, right? And in respiratory tract we know that the purpose of cilia is protective, it is defensive, right? Then columnar means the cells are taller, right? So if I draw a columnar cell, so cell will be something like this, okay, and then it will have a nucleus. So the cells are taller, so this is columnar. Now what do you mean by the word pseudo-stratified? Stratified means multiple layers. Stratified means multiple layers, and if we use the word pseudo, it means there is only one layer but it looks like multiple layer, right? So there is only one layer but it looks like multiple layer, so that is known as pseudo-stratified. Now if I draw a diagram of stratified epithelium, like if I draw stratified, so suppose this is the basement membrane, okay, this is the basement membrane, and stratified means there are multiple layers, like this is one layer, okay, then on the top there is another layer, on the top of that there might be one more layer, and then you will have nucleus, right? So this is stratified, you have multiple layers, okay, each cell having its own nuclei. Clear? So this is stratified columnar, fine. So this is stratified columnar. Now if I draw pseudo stratified columnar, so this is the basement membrane and there is only one layer of cells, okay, so cells are something like this, There is only one layer of cell. Okay. And what happens? The nucleus, they are at uneven levels. Some here, some here, some. Okay, like this. So the nucleus, they are at uneven levels, and therefore from a distance it looks like as if the epithelium is multi-layered or pseudostratified, but in reality there is only one layer. So this is known as pseudostratified. Understood? So, and if I put cilia on the top of this, right, so it becomes ciliated pseudostratified columnar. Fine. So this is the concept of pseudostratified columnar epithelium. And here you can see in the image, you can see these are the cilia, right? And there is the nucleus. These are all nucleus. Okay. So these. So you can see the level of nucleus, they are uneven. In some cells it is at the upper side, in some others it is on the lower side. So this unevenness of the location of nucleus creates a false impression as if these are stratified, but in reality it is not stratified, and therefore we use the word pseudo stratified. Clear? So this is the concept of pseudo stratified epithelium in the respiratory passage except vocal cords. Now next question. Mother came to pediatric OPD and she complained there is a soft defect on the anterior part of the skull of the child, and she is worried. But as a doctor, you know that there is nothing to worry. That's a normal thing. So what you will say? That when it will disappear. So this actually defect on the anterior part of the skull is nothing except anterior fontanelle. So this is the anterior fontanelle, right, which is also known as the bregma, and this disappears by the age of, or this fuses or ossifies by the age of 12 to 24 months, right? So in a newborn, anterior fontanelle is there. That is a normal thing, but it will take around maximum of 2 years to ossify or solidify, and then it won't be, that depression won't be felt anymore. So you can tell her that don't worry, it's a normal thing, right? So if you look here, this is the anterior fontanelle, right? So this is the anterior fontanelle. Clear? And posteriorly, this is the posterior fontanelle. So this is the posterior fontanelle. Posterior fontanelle, that is lambda, it ossifies little early, somewhere around the age of 6 months, right? So it gets ossified by 6 months, and anterior fontanelle 12 to 24 months. Clear? So this is the normal time period after which these fontanelles would not be appreciated as depressions. Clear? So these are. Now one more clinical question. A person had a fall on outstretched hand like this, and then he had injury somewhere at the base of thumb, right? So this area is the base of thumb. Now what injury can occur here at the base of thumb, right? Whenever we are discussing the base of thumb, we are more interested in discussing the base of first metacarpal, right? So if someone tells you there is injury at the base of thumb, there is injury of base of first metacarpal. Clear? So base of first metacarpal. And we know that there are two fractures which are discussed in relation to the base of first metacarpal, and either it can be Bennett's or Rolandos, right? So Bennett's or Rolandos. And these two, they differ in the anatomy as such. So suppose if this is the first metacarpal, in Bennett's fracture, there is a simple fracture line. So this is Bennett's fracture, right? So this is Bennett's fracture, and again this is an intra-articular fracture. Now if we talk about the Rolando's fracture, the configuration here, it looks like the alphabet T or Y. So it can be either T, right, or it can be alphabet Y, right? So it can be like, the fracture line can be like this, right? So this is the Rolando's fracture. Clear? So base of thumb is actually some injury related to the base of metacarpal, and the fractures which are discussed in relation to the base of metacarpals are the Bennett's or Rolando's, right? I think most of you must be knowing that scaphoid is the base of anatomical snuff box, right? Not at the base of thumb. So, and Cooley-Smith's distal end of radius. So anyway, this is the question. And if you look here in the image, you can see that, see here, you can see a linear fracture line shown in the red color, right? So this is a linear fracture line, that is Bennett's. And if it is anything like Y or T, that is Rolando's. Like for the classical description for Bennett's is intra-articular fracture, and Rolando's is intra-articular fracture with comminution, right? So therefore the appearance is Y or T shaped, right? So this is base of first metacarpal. So this is the first metacarpal actually, and this is the first metacarpal base, right? And lower down, this is triquetrum, right? So this is base of first metacarpal. Now next question, a patient has infection in the cavernous sinus, and later on it involved a cranial nerve, and it was assumed that it is the abducent nerve which is involved. Now how you will check the involvement of abducent nerve? So I think cranial nerve number 6, it supplies only one extraocular muscle, and that is lateral rectus, right? So if suppose these are the eyes, function of lateral rectus is to move the eyeball outward. Okay, so this is function of lateral rectus, and therefore what you will tell the patient? You will tell the patient to look laterally outward. So that way you can check lateral rectus. And I think you must be remembering the formula LR6, SO4 rest by third for the nerve supply of extraocular muscles. So this is how you will check. Now coming to, more importantly, coming to the cavernous sinus, I think this is an important topic, and many years later we have a question on this topic. Now here, cavernous sinus is one area. It's actually a venous channel, and it has got few cranial nerves which are lying in very close proximity, right? So like if I draw cavernous sinus, one on either side, so suppose if this is the cavernous sinus, okay, there is third nerve, right? So cranial nerve number 3. Then lower down we have cranial nerve number 6. Then even lower down we have 2 segments of the trigeminal nerve, right? So ophthalmic and maxillary, 5.1, 5.2. Within the substance of the cavernous sinus, there is, within the substance of cavernous sinus, there is 6th nerve, right? This is the 6th nerve, right? So you can see 3rd nerve, 4th nerve, 2 divisions of the 5th nerve and 6th nerve. All these nerves are lying within close proximity of the cavernous sinus. And there is one condition which is known as cavernous sinus thrombosis. In such case, there is simultaneous involvement of these cranial nerves. So in terms of extraocular muscles, if there is simultaneous involvement of 3rd nerve, 4th nerve and 6th nerve, think of the possibility of cavernous sinus thrombosis, right? So this is a very important area, because if there is any thrombosis here, you can have involvement of all the 3 cranial nerves which are supplying the extraocular muscles, right? And in relation to cavernous sinus, I think there is one dangerous area of face, because the area of face which involves if I draw it, like suppose if these are the eyes, this is nose, and then this is the lips, right? So this area, something like this, this area is known as the dangerous area of face. Okay, so this is known as the dangerous area of face. And why it is known as dangerous areas of the face? Because if there is any infection in this part of the face, it have a direct communication, a valveless communication with the cavernous sinus. So any infection here can spread directly to the cavernous sinus. So therefore it is known as dangerous area of face, and infections in this particular part of the face should be managed judiciously and very vigilant. We have to be very vigilant while treating infections in this area. Otherwise the patient might have cavernous sinus thrombosis, and then the manifestations are widespread because it can involve all the 3 nerves, 3rd, 4th and 6th. So this is one very beautiful concept, and a question has been asked on this after a long time. Again, an important segment, cavernous sinus. Then next question. Now this is also a very good question, and here after a injury, patient was able to flex MCP joint, okay, and extend IP joint. So flexion of MP joint, this is metacarpophalangeal joint. So flexion at MCP joint, and these are interphalangeal, proximal and distal. So patient can do this kind of posture. It means it can flex the MCP and it can extend the IP joints, but he is not able to extend. Now this is flexion of MCP joint, and this is the extension at the MCP joint. So patient can do this, but patient cannot do this, right? So it suggests that the extensors of the MCP joint are paralyzed, right? So the extensors of the MCP joints are paralyzed. Now these extensors of the MCP joint are supplied by the posterior interosseous nerve, which is a branch of radial nerve. Okay, so here the answer is posterior interosseous nerve, and yes, it is a branch of radial nerve. So you can say D is a better answer than A in this particular case if options are something like this, right? Now what actually the clinical condition the patient has developed. It is known as finger drop, right? So patient can extend the wrist, so it means there is no wrist drop, but patient cannot extend the fingers, only the fingers are lying something like this. So this is finger drop, a very classical presentation of posterior interosseous nerve injury, right? And this scenario has been given in relation to trauma. In clinical practice, whenever we are operating our whenever we are operating for fracture radial head, so fracture radial head or radial neck, and if there is not, if the surgical technique is not proper, like we have to retract the supinator muscle properly, because the posterior interosseous nerve is related to the supinator muscle. So if supinator muscle is not retracted properly during surgery, then there are chances that the patient might develop finger drop, and that is because of paralysis of posterior interosseous nerve, right? So this is finger drop. Anyway, so now next question. This is one more repeat question, only the presentation has changed and the answer remains the same. So here some surgical procedure was carried out on a vein which is running 2.5 centimeter anterior to the medial malleolus. Now when we are ligating this vein, which nerve should be protected from accidental ligation or accidental injury, right? So here you have to answer two things first, like which nerve, which vein is this? So this is actually the great saphenous vein, right? So the great saphenous veins runs on the medial side of the leg and passes from the dorsum of the foot through the dorsal venous arch, ascends upward around 2.5 centimeter anterior to the medial malleolus, right? So that is great saphenous vein, and the procedure which is being discussed in this question is actually venesection, that we do for burn patients when we have to give a large amount of IV fluid. So we do venesection, right? So while we give a cut in the great saphenous vein, we pass a Ryle's tube, and then this Ryle's tube has to be secured over from the proximal part of the vein, and for that we pass a ligature so as to secure it. And sometimes there is possibility that the saphenous nerve which is lying by the side of the vein, it can also be included in that ligature, right? So while doing this, while securing the Ryle's tube with the ligature, make sure that you don't include the saphenous nerve into that ligature, because if you tight the ligature, you are compressing the saphenous nerve as well, right? So the answer is saphenous nerve. And here you can see burn patients, clear? So whenever we are putting the ligature to hold the Ryle's tube, we have to be very careful, right? So this is saphenous nerve. Then there was a question about the Cunard segments, and there was an arrow which was towards one particular segment, and it was asked like what was the number of that particular Cunard segment, right? So this is actually number 8. Okay, so 6, 5, 4A, 4B, 2, 3 is already, and this is 1. Clear? So this is the nomenclature what we usually do, and based on the tributaries from the hepatic vein and the portal vein, right? So these are the Cunard's segment, and the smaller one, this is segment 1, which is also known as the caudate lobe. This is the caudate lobe. this is the quadrate lobe. Here, so the arrow was on segment 8. So this is how you can just remember the segments and see the segment 1 is seen. This is the segment 1. Okay, right? So this is the segment 1, right? And this was the one which was asked in the exam, segment 8. So these are the Quinaud's segment. Now again, next question, it was clinical. A surgical procedure was done for patent ductus arteriosus. Now there is possibility of injury to some nearby structure which are lying in close proximity to the ductus arteriosus. Now for that you need to understand what actually is the anatomy of ductus arteriosus. So suppose if this is the pulmonary trunk, okay, so this is the pulmonary trunk, and then this is the arch of aorta. Okay, this is the arch of aorta, right? And this is the communication between the two, and this is the ductus arteriosus of fetal life, right? So this is main pulmonary trunk, this is the aorta, right? So in fetal life, ductus arteriosus is very important, but as soon as the baby is born, it should obliterate, it should disappear, and it persists as ligamentum arteriosum. Clear? So it persists as ligamentum arteriosum in adult, but in some children's it fails to obliterate, and then it is known as patent. Patent means open. Now this is not a acceptable entity, because what happens, the blood can go from aorta to pulmonary trunk, so it is actually a left to right shunt. Okay, so it should be closed. So while doing surgeries, there is possibility of injury to the left recurrent laryngeal nerve, which actually hooks under the pulmonary and the ductus arteriosus, right? So it actually passes like and then goes like this. So it is actually passing behind or below the ductus arteriosus. So whenever you are doing, this is left recurrent laryngeal nerve. Okay, so whenever you are doing any operative procedure over the patent ductus arteriosus, there is possibility that you might injure left recurrent laryngeal nerve, right? So this is very important. So again, if you can see here, this is the pulmonary trunk here. Okay, so this is the pulmonary trunk, and then this is the aorta, and you can see this is the communication, that is the ductus arteriosus, and the nerve is looping below the patent ductus arteriosus. So it has got, this is left recurrent laryngeal nerve, right? So again, it is a branch of vagus nerve. So there is possibility that while you are operating over the patent ductus arteriosus, if you are not vigilant enough, you can injure this. Now what will be, no, this is a very straightforward question this time. There is possibility that maybe next time you can have a clinical presentation based question. So if there is injury to left recurrent laryngeal nerve, what can happen? There is paralysis of all internal laryngeal muscles except cricothyroid. Why? Because cricothyroid is supplied by external laryngeal nerve, right? So it has got a different nerve supply, so it is spared. External laryngeal nerve. Also, it provides sensory innervation below the level of vocal cords. So anesthesia below the level of vocal cords. Clear? So this is manifestation actually of recurrent laryngeal nerve injury. Clear? So this is very important. Before moving on to next question, we can take a 5 minutes break, not a lengthy break, right? So just a 5 minutes break, right? So just a short break, right? Hello dear students, welcome back, and now we will move forward to one question which was from a very tough topic as far as the anatomy of the head and neck is considered, and it was asked for the very first time from this particular topic. Now here a point was marked in the skull, and then it was asked like which ganglion might be injured if there is injury to this particular landmark, right? So if you can see here, you can see this is the area which is highlighted, and it was asked like the ganglion which might get injured if there is injury to this particular area, right? So let us firstly see the surrounding bones in relation to this particular landmark. Now this is zygomatic arch. Okay, so this is the zygomatic arch. If you see this is all maxilla. Okay, so this is maxilla. Posteriorly, if you see, this is all pterygoid, which is a part of pterygoid plate, which is a part of this sphenoid bone, right? So the question was about this particular area, and this is the Pterygopalatine fossa, right? So it is better visualized when we remove, when we just take this area out from here, right? So this area has to be cut and it has to be removed. Then we can see the entire extent of the Pterygopalatine fossa, right? So the landmark which we are interested in discussing in this question is the Pterygopalatine fossa. Clear? Now I think most of you can understand why we are using the word pterygo, because it has something to do with the pterygoid plate, and more specifically it is actually pterygoid process, right? And then the another word here is palatine. Now palatine is the word, and it has been derived from the palatine bone. Yeah, so it is just because there is some contribution of that palatine bone as well, and therefore this area is known as the Pterygopalatine fossa. Now as far as the answer is concerned, the moment you get to know the landmark, that is Pterygopalatine fossa, you can say that the ganglion here is Pterygopalatine ganglion, right? So this is the question. Now we can, here if you see, this is all pterygoid plate, right? Anteriorly this is all maxilla. This is all maxilla. Okay, so I think it's better we can take this thing, we can discuss this thing in short with the help of diagrams. If you can see here, these are teeth in upper socket. So this bone is maxilla. Clear? This is maxilla. This is the pterygoid plate of sphenoid, right? And you can see the this all area is the Pterygopalatine fossa. Okay, so this is all Pterygopalatine fossa. Clear? Now this is little difficult, because unless and until you see the skull in hand, it is quite difficult to understand about this particular landmark. But anyway, I'll try to simplify the things so that you can understand at least something, right? And here you can see this is the Pterygopalatine ganglion. So this is the Pterygopalatine ganglion, right? So now this is the right sided Pterygopalatine fossa, right? So this is right-sided Pterygopalatine fossa. If we visualize this fossa from above, like on the right side image, so this part is anterior, this is posterior, this is lateral, and this is medial. So this is again, we are discussing the right sided Pterygopalatine fossa. Anteriorly, we discussed that there is maxilla. So this is anteriorly, we can see the maxilla is here. Okay, so this is all maxilla. Okay, and then posteriorly, you can see there is foramen rotundum, and if I draw it in the diagram, this is the foramen rotundum, and through the foramen rotundum there is emergence of the second division of trigeminal nerve, that is the maxillary division, right? So this is the foramen rotundum here. And through the foramen rotundum there is this cranial nerve second division, that is maxillary division. Clear? This is one important branch. Then slightly on the medial side there is sphenopalatine foramen, and through this sphenopalatine foramen there is the entry of the nasopalatine nerve. So if you see, this is the sphenopalatine foramen. Okay, so this is the sphenopalatine foramen, and which is onto the medial part of the Pterygopalatine fossa. So this is the sphenopalatine foramen, right? So, and anteriorly this all is maxilla. So these are the boundaries of Pterygopalatine fossa, and Pterygopalatine fossa is the landmark of the skull which is related to Pterygopalatine ganglion, right? So this is slightly difficult teaching it in terms of theory. It's better correlated well on the skull, right? So this is the Pterygopalatine fossa, and just for the time being, please remember Pterygopalatine ganglion which is related to it, right? So somewhere here is the Pterygopalatine ganglion, right? So this is the Pterygopalatine ganglion, right? So just remember this much. Otherwise it is slightly confusing and not easily understood. And here also you can just, if I draw it, I'll try if I can simplify it. So this is 1, this is 2, and then if we connect it, so this is the pterygomaxillary fissure. Again, the word pterygo is related to the pterygoid plate. This is the pterygoid plate, and then maxillary is, of course, I think most of you can understand that this is maxilla. So pterygomaxillary fissure. Medial to this is Pterygopalatine fossa. Okay, so outermost is pterygomaxillary fissure. Medial to that is Pterygopalatine fossa, and still medial to that is the sphenopalatine foramen, or you can say opening, right? So again, the word spheno is derived from sphenoid bone, palatine is derived from the palatine bone. So this is the typical relationship of the different landmarks as we grow from lateral to medial, right? So this is medial. So lateral to medial, if we go something like this, here we have the pterygomaxillary fissure, then we have the Pterygopalatine fossa, and medial most we have the sphenopalatine foramen, right, connecting to the nasal cavity. So this is Pterygopalatine fossa. Okay. Now, this is a slightly tough question, and I think a little difficult on the part of the student to answer unless and until he knows the exact anatomy of the Pterygopalatine fossa. Otherwise, it is slightly difficult. Then next question, a patient has injury to the area marked 2. Now, what will be the clinical manifestation? So, image was given, and it should not be area 2, it should be area 3. Please correct, it should be area 3, right? So, firstly, we have to identify what area number 3 is. So, if you see here, this is area number 3, right? So, this is area number 3, and area number 3 is actually cribriform plate of ethmoid. Okay, so it is cribriform plate of ethmoid, and through this there is passage of the olfactory nerve fibers. So the olfactory nerve fibers goes upward like this. Okay, and then we have the olfactory bulb here. This is the olfactory bulb, and then the olfactory nerve as such. This is the olfactory bulb. Clear? So, and these are the olfactory nerve fibers. So I think with this much of discussion, you must have understood what actually the question is asking for. Any involvement of the olfactory fibers which are passing through the cribriform plate would lead to loss of smell, that is anosmia. So this is loss of smell, right? So this is cribriform plate of ethmoid bone. Now this is one thing in relation to injury to the olfactory fibers. This cribriform plate of ethmoid, now if suppose this is cribriform plate of ethmoid, on the top of this is anterior cranial fossa. Clear? So this all area is anterior cranial fossa. Lower down is all nasal cavity. Clear? So this is the nasal cavity. Now this cribriform plate of ethmoid bone is acting as a barrier between the anterior cranial fossa and the nasal cavity. Here we have CSF which is surrounding the brain. So suppose if there is a case of road traffic accident and if there is fracture of cribriform plate of ethmoid bone, what will happen? The CSF will leak from the anterior cranial fossa and it will come to live. It will come within the nasal cavity, and then it can come out through the nostrils, and this is known as CSF rhinorrhea, right? So this is one more important segment which is a part of MCQ in fact. So although in this question it was a different presentation, but usually the question is about CSF rhinorrhea, and the answer is again the fracture of cribriform plate of ethmoid bone, right? So here, since the olfactory pathway can be injured, so it can lead to loss of smell sensation, that is anosmia. So here again you can see this is olfactory bulb. Okay, this is olfactory bulb. These are olfactory fibers or nerve fibers, and these are passing through the cribriform plate of ethmoid. So you can see these are the fibers which are ascending like this. This is anterior cranial fossa, this is nasal cavity, and here we have CSF, right? So this is how If there is fracture of the cribriform plate of ethmoid, it can lead to, not only it can lead to the involvement of the olfactory nerve fibers, but it can also lead to leakage of CSF from the anterior cranial fossa through the nose, and the condition is CSF rhinorrhea, right? So this is one thing. Now next question, primary lymphoid organ. Whenever you have this word primary lymphoid organs, you have to remember only two terms. One is thymus and second is bone marrow. Clear? So these are the primary lymphoid organs, and therefore your answer will come out to be thymus. Lymph node, spleen, these are all secondary lymphoid organs. Now the primary lymphoid organs, these are also known as the central lymphoid organs, and they don't have anything to do with antigen. What they are concerned with? They are concerned with production of WBCs, right? So you must have heard of T cells, B cell. Clear? So these are produced in the primary lymphoid organs, or the central lymphoid organs, that is thymus or bone marrow. Okay, and then they have nothing to do with antigen presentation. Right? But on the other hand, the secondary lymphoid organs like lymph node, spleen, they, and even like tonsils, adenoids, spear patches of intestine, they are related with antigen involvement and then the immune response, right? So these are the secondary lymphoid organs. Okay, so it can, these are all secondary lymphoid organs. Clear? So this is the concept of primary and secondary lymphoid organs. Now next question, which of the this ends the anatomy part. Now we will start the medicine part. Now primary hypothyroidism, I think hypo means less, so less functioning of thyroid gland, and when we use the word primary, it means the pathology is in the thyroid gland itself, right? Is having problem. Okay, so it is primary. And what will happen, because see, thyroid gland, it will produce T4, T3, right? So if there is less functioning of thyroid gland, there will be less amount of T4 and T3. Now what will happen, because of the negative feedback, so it will go to anterior pituitary, and this will stimulate, or this will lead to excess production of TSH, which actually is trying to stimulate thyroid gland to produce more of T3 and T4, right? So in a case of primary hypothyroidism, the classical lab values will be less of thyroid hormones and more of thyroid stimulating hormone from anterior pituitary, right? So that is what you will get in a case of primary hypothyroidism. Now there is possibility that thyroid gland is okay, but the pituitary gland is at fault. So pathology in anterior pituitary. So what will happen? Because of this, there will be less TSH, and if there is less TSH, there will be less command to thyroid. So this will also result in less thyroid hormones, right? So if you have this kind of presentation, think of secondary hypothyroidism. In primary, TSH levels will be always high. Clear? So this is how we clinically differentiate between primary and secondary. Okay. Now, a known case of diabetes patient was on some anti-diabetic agent, and then there is risk of hypoglycemia. Which drug can lead to this kind of complication? Now remember, any anti-diabetic drug which promotes release of insulin, and we know that in the action of insulin is to decrease blood glucose. So any anti-diabetic drug which has this tendency to promote release of insulin will have a risk of causing hypoglycemia, and this is especially seen with sulfonyl ureas. Okay, so this is especially seen with sulfonyl ureas, especially glympyride, right? So this is very important here. And although vildagliptin also act in this manner, but more risk of hypoglycemia with glympyride. So that promotes release of insulin, right? So these are known as insulin secretagogues. Secretagogues means promotes secretion. Okay, so this is especially seen with sulfonyl ureas, especially glympyride. Okay, so hypoglycemia remains a major adverse effect here, right? And there is one more anti-diabetic drug for which you should remember its complication, and the complication actually is lactic acidosis, and that is related to the biguanides, that is metformin or fenformin, right? So these two drugs are extremely important in terms of their adverse effects: hypoglycemia for sulfonyl ureas and lactic acidosis for biguanides. Okay, so just remember this much. So for this particular question, the answer is glympyride. Now next question. Now this is a repeated question, like long-term glucose control. I think everyone can answer this because it is a common question which has been repeated over the years, and this is glycosylated hemoglobin, which tells about average blood sugar levels in past 3 months. Okay, so this is glycosylated hemoglobin, and there is one more entity. This is serum fructosamine. This is giving us assessment of blood glucose for previous 3 weeks. Now this one is preferred in cases of pregnancy, right? Gestational diabetes, you can say. And why this is very important? Because we know that if there is maternal diabetes, it can cause not only it can cause complications in mother, it can also cause complications in fetus like fetal macrosomia or other defects, right? So in pregnancy we have to check the blood sugar, and we have to repetitively use serum fructosamine if we want to check the average blood sugar levels for previous 3 weeks, right? So for long term, remember glycosylated hemoglobin. Then next question, the auscultatory areas were given, and we have to identify which area is for which, like the labeling is for which auscultatory area. So if you look here, now this is second rib, right? So this is the second rib, and below the second rib we have the second intercostal space, right? And if I draw the outline of sternum, So this is somewhat the outline of sternum, something like this. Okay. So this is the outline of sternum. This is manubrium. Okay. Right. So, and you can say this is the angle of Lewis. This area is the angle of Lewis, and we know that angle of Lewis is the point of attachment of the second rib onto the sternum, right? So you can see this is the second rib, right? So this is the second rib, and this is also an important landmark for counting ribs. So we can feel the angle of Lewis, and lateral, if we go on either side, we can feel the second rib. Below the second rib is the second intercostal space. Now in the second intercostal space, on the right side, this is the right, this is the left. On the right side, we have the aortic area. So A is the aortic area, right? So this is aortic area, and B is the pulmonary area. Okay, so this is pulmonary area, right? So this is on the right side, aortic auscultatory area, left the pulmonary auscultatory area. Clear? So these two are in relation to the second intercostal space. Lower down, if we go, this is the fifth rib. Okay, so this is the fifth rib, and below the fifth rib is the fifth intercostal space, and fifth intercostal space somewhere in the mid axillary line, something like this. This is the mitral auscultatory area. So this is the mitral area, right? So in the fifth intercostal space. Okay, and also somewhere in the fifth intercostal space we have the tricuspid area. So the tricuspid area is somewhere here in the fifth intercostal space, just medial to the border of the sternum, right? So this is aortic, this is pulmonary, this is tricuspid, and this is mitral, right? So the labeling should be aortic, pulmonary, tricuspid, mitral. Okay, so this should be A, B, C, D. You can keep it like that. Okay, so this is very important. So again, if in the diagram, if I show you, this is the second rib. Okay, this is the second rib, and below the second rib on the right side we have the aortic area, right? On the right side in the second intercostal space, just by the side of the sternal margin. On the left side we have the pulmonary area, right? So these two are in the second intercostal space on either side of the sternal border. Then when we come to the fifth intercostal space, just by the side of the, you can say, left sternal border, we have the tricuspid area, and in the fifth intercostal space, somewhere in the mid axillary line. Now this is the mid axillary line, mid clavicular, I'm extremely sorry. So this is mid clavicular line, right? So this is the mitral area. So mitral and tricuspid, fifth intercostal space. Okay, so just remember aortic, pulmonary, tricuspid, mitral. And please note that these are auscultatory areas where we will hear the murmurs, if any, better, and this doesn't coincide with the actual location of the valve, right? So the actual location of valve is different, and the area where we hear the murmurs more perfectly are different. Like if you say this is the location of aortic valve, right? Then just medial to that, just on the left side, we have the mitral valve, right? Slightly lower down, we have the tricuspid valve. This is the tricuspid valve. Okay, and this is the, okay, so this is the pulmonary valve, right? So you can see that the location of the valve areas is entirely different from the areas where we will hear the murmurs related to the dysfunctioning of those valves, right? So auscultatory areas are different from anatomical location of valves. Clear? Okay, so this is to be noted. Fine. So anyway, this is aortic, pulmonary, tricuspid, mitral. Now ECG was given, and it was of a patient who has presented with chest pain, and this is the moment you have a case with severe chest pain, the very first thing which comes to your mind is possibility of myocardial infarction. And whenever you think of myocardial infarction, what you have to look in ECG, look for ST segment elevation. Clear? So look for ST segment elevation. Now, depending on the leads in which there is segment ST segment elevation, we can presume that which part of the heart has undergone myocardial infarction, right? So suppose if we have this 12 lead ECG, right? So firstly we will see where we are getting the ST segment elevation. So we are getting the ST segment elevation here, right? We are getting the ST segment elevation here, we are getting the ST segment elevation here, and we are also getting the ST segment elevation here. So what actually, where we are getting, this is lead V1, this is lead V2, this is lead V3, and this is lead V4, right? So now the V1 and V2 is actually suggestive of septal MI. So if you are getting ST segment elevation in V1, V2, we will say it is a case of septal MI. If there is elevation in V3 and V4, you will say that it is a case of anterior wall MI. Clear? So now we are getting V1, V2, V3, V4. So we can use a collective term, that is anteroseptal, right? So if you have all these four, you can say anteroseptal MI. And if in the option you don't have anteroseptal, you can specifically go for anterior wall MI, right? So this is for anterior wall or anteroseptal MI. Clear? So this is how you, firstly you have to see what is the location of ST segment elevation, in which lead you are finding, and based on that we have, because specific leads or set of leads, they reflect the MI changes in specific portions of the heart. So this is for septal or the anterior wall of heart, right? So, and suppose if you are getting ST segment elevation in lead 1, AVL, V5 and V6. Suppose you are getting in 1, AVL, V5 and V6, then this has to be labeled as lateral wall MI. Clear? So if you are getting in 1, AVL, V5, V6, this is lateral wall MI. And in case if you are getting ST segment elevation in lead 2, lead 3 and AVF, you will call it, so lead 2, lead 3 and AVF, this will be termed as inferior wall MI, right? So you have to just look at the ST segment elevations in whatever leads, and then based on those specific set of leads, you can say whether it is a case of anterior wall, lateral wall, or inferior wall MI, right? So this is how you can get up to the answer. So in this particular question, since it is involving V1, V2, V3, V4, you can write anteroseptal, or if anteroseptal is not there in the option, you can write anterior wall MI, right? Now, next question is about small sign which is not seen in. Now, for this, you should understand what is small sign. Normally, what happens when we inhale, right? So, on inspiration, what will happen to the intrathoracic pressure? There is a fall in intrathoracic pressure, right? So the intrathoracic pressure will fall and it creates a negativity. So creating negativity, and therefore the jugular column of blood also falls. So this jugular column also falls. Now this is the normal physiology, right? So this is the normal physiology. Now what is Kussmaul sign? In Kussmaul sign, jugular column remains elevated even during inspiration, right? So the jugular column, which was supposed to fall down during inspiration, it remains elevated. So that is known as Kussmaul sign, and it can be seen in constrictive pericarditis, it can be seen in restrictive cardiomyopathy, or even it can be seen in tricuspid stenosis, right? So the answer to this question comes out to be the cardiac tamponade, right? So this is Kussmaul sign, and if you look here, this is the jugular column, and you can see it is so prominent, and this suggests either constrictive pericarditis or restrictive cardiomyopathy or tricuspid stenosis. Now next question, rescue percutaneous coronary intervention. Whenever we say percutaneous coronary intervention, it means we are discussing about stenting. We are putting a stent in the atherosclerotic area of the coronary artery, and we try to open up the lumen. Instead, it is blocked lumina to promote blood flow. Clear? So this is stenting, or which is known as PCI. Now this is done especially if the thrombolytic therapy fails. Like we are trying to dissolve that clot. So lysis means destruction. Thrombus is actually the atherosclerotic plaque. So we try to just remove that obstruction by doing thrombolysis, and also we give antiplatelet therapy. If these conservative modes fails, then definitely we have to go for percutaneous coronary intervention, and then it is known as the rescue PCI, that is percutaneous coronary intervention, right? So this is the usual sequence. Initially we start with drug therapy, and if it fails, we need to go for intervention in the form of putting stents, right? So here you can see this is the blocked area, right? And we have kept this stent here, and in an attempt to open up the lumen so as to restore the blood flow. So this is stenting or percutaneous coronary intervention. Clear? And many times you must have heard of the word angioplasty, right? So angioplasty. So that is all synonymous things. Now next question about a lady who is having unilateral throbbing headache, and this aggravates on exposure to bright light, and she also skips her breakfast occasionally. The moment you get any word like unilateral headache, the answer should be migraine, right? So unilateral throbbing headache, which can be precipitated by an exposure to bright light or skipping meals, that is migraine. This is very important, right? And about tension headache, there will be a feeling of rope tied across head, right? So patient will think as if some rope has been tied across my head and it is being stretched, and there is that compressive feeling, like that is tension headache. And in cluster headache, usually the headache is around the orbital area. So orbital area, right? So very easy to diagnose tension headache or cluster headache. So if you see, the patient will feel as if some there is some squeezing sensation around the head, and in case of cluster headache, the pain is especially around the eyeballs or the orbital region, right? So again, this is very severe pain around the eye. So migraine, tension type headache or cluster headache, quite easy to differentiate from each other based on their typical presentation. Frontal sinusitis, this produces office headache, and this shows periodicity. Clear? So pain will start at 9 a.m., peaks at 12 noon, and disappears by 5 p.m. Clear? So that is the classical presentation of frontal sinusitis. So this is migraine. Now next question, and this is again a very important topic, and no exam is ever complete without taking one question from this segment, that is of meningitis. So if a patient is having meningitis showing low sugar, raised proteins, and elevated polymorphonuclear cell count. Now polymorphonuclear cell count is actually neutrophils, right? So I think most of you, the moment you find neutrophils or polymorphonuclear cells, the answer has to be bacterial meningitis, right? So because decreased sugar, raised proteins, this can be seen in tubercular bacterial meningitis, but here the cell is lymphocytes. Clear? So just looking at the cells, we can say whether it is a case of tubercular meningitis or it's a case of bacterial meningitis, right? So this is important here. And in cases of viral meningitis, again we will see increased lymphocytes, but how it can be differentiated from bacterial tubercular meningitis, because in tubercular we have also increased lymphocytes. Here we will look for the level of sugar. So sugar in CSF is normal, but in tubercular the CSF sugar is reduced, right? So this is how we can differentiate the viral from the tubercular meningitis. And tubercular from bacterial can be differentiated by the type of WBCs which are elevated in CSF sample. Okay, so again, this is a very important segment. Please try to be thorough with this particular topic. Now, next question. It's a patient who is having bulbar paresis and autonomic involvement, and he showed an incremental response. Now, this is very important. Incremental response on repetitive nerve stimulation test. So this is very important here, incremental response. And if you have ever studied about the symptomatology of a myasthenia gravis patient, they have increased muscle weakness during the evening hours. So like from morning to evening, they will use the muscles, and what will happen? More the muscle use, more will be the weakness in the muscle, and that is reflected as a decremental response on nerve stimulation test. Incremental means if the muscles are used more, patient will feel better. In decremental, if the muscle is used more usage of muscles lead to weakness of muscles. So this is decremental, and this is very important of myasthenia gravis. Clear? So the moment you find the word incremental, what you can do? You can clearly rule out two conditions, that is myasthenia gravis and the ocular and the generalized myasthenia gravis. Now, this presentation goes more in favor of Atten-Lambert syndrome. So just few differentiating points between Atten-Lambert syndrome and myasthenia gravis. Now, in both the conditions, there are antibodies. In myasthenia gravis, the antibodies are against the acetylcholine receptors on the postsynaptic end, whereas in Lambert-Eaton syndrome, there are antibodies, but they are directed against the voltage-gated calcium channels in the presynaptic area, right? So one entity is presynaptic pathology and another is postsynaptic, right? So Lambert-Eaton syndrome is presynaptic pathology and myasthenia gravis is postsynaptic pathology. Yeah, both are antibody mediated, having antibody mediated damage. Now, autonomic involvement is seen in Lambert-Eaton syndrome. This is not seen in myasthenia gravis. So this is one more feature which goes in favor of Lambert-Eaton syndrome, right? This is one important feature. Then most important is the response of repetitive nerve stimulation test or continued usage of muscles. This is incremental response. Weakness improves with contraction. But in a case of myasthenia gravis, there is decremental response. Weakness aggravates or worsens with continued muscle usage, right? So these are few important difference between Lambert-Eaton syndrome and myasthenia gravis. And of course, the antibodies which are formed in Lambert-Eaton syndrome are against the voltage-gated calcium channels of presynaptic area. In myasthenia gravis, these are against the acetylcholine receptors on the postsynaptic part, right? So this is the location of the acetylcholine receptors in the postsynaptic part, against which there are antibodies in myasthenia gravis, and these are the voltage-gated calcium channels against which there are antibodies in Lambert-Eaton syndrome, right? So these are two entities which needs to be differentiated, right? So for this particular question, the answer is Lambert-Eaton syndrome, right? So this is very important, incremental response. The next question, a person was unable to open the mouth and there is muscle weakness and it was diagnosed as a case of botulism. Now, what is the mechanism of action of this botulism toxin? Now, here, this toxin hampers with the functioning of SNAP protein, which is needed for the release of acetylcholine, right? So this SNAP protein is needed for the release of acetylcholine from the presynaptic end into the synaptic cleft, because then only it can cross the synaptic cleft to bind with the acetylcholine receptors, right? So these are the synaptic vesicles in which we have acetylcholine neurotransmitters. Now, they are present in the presynaptic, this is presynaptic area, right? And they need to bind to the presynaptic membrane before releasing all the neurotransmitters. So this SNAP25 is hampered with, and that interrupts the process of this release of neurotransmitter from the synaptic presynaptic vesicles, right? So these are actually presynaptic vesicles. Okay, so this is the pathology in botulism, right? Now, this is one more repeated question, and it has been asked many number of times. Most sensitive test for myasthenia gravis, and the answer is straightforward. This is single fiber electromyography. Most sensitive, right? So this is most sensitive. And we can also do antibody estimation which are against the acetylcholine receptors. So these also can be done, but sensitive is always single fiber electromyography. Now, next question. In a case when bronchoalveolar lavage was done, we have got a microscopic picture. So we have to identify the agent and then the treatment of that agent. Now, this is a case who is suffering from pneumonia, right? And here what we can see in the image, if you look properly, you can see a structure something like this, and inside that you can see multiple nuclei something like this, right? So this is the impression from this picture, and this is a classical microscopic image of Pneumocystis 0HE, which was previously known as Pneumocystis carinii. And I think most of you must be knowing that we give cotrimoxazole for Pneumocystis 0HE pneumonia, right? So this is a classical microscopic picture. And if we take a little bit of discussion, so again you can see here, this is actually a cyst, and it has got multiple nuclei which can range from 4 to 8. So this is the classical picture. The moment you see this kind of microscopy in a case of bronchoalveolar lavage or induced sputum production, and then microscopy of that induced sputum, so think of Pneumocystis 0HE, and which should be managed by cotrimoxazole, right? Then another question was about unconjugated hyperbilirubinemia. Okay, so unconjugated. Now, I think most of you must be knowing what actually conjugation is, because whenever there is breakdown of RBC, there is liberation of hemoglobin, right? So this globin is protein, it goes to protein pool, okay, and this hemo is actually heme, which will break down to liberate biliverdin, which will convert to bilirubin. Now this bilirubin is highly toxic, and therefore it is brought to the liver for conjugation. Clear? So, and after conjugation, it is sent through the common bile duct to the second part of duodenum in the ampulla of wet air, right? So this is the usual mechanism for bilirubin metabolism. Now, if there is any pathology which hampers the process of unconjugation, it will result in increased unconjugated bilirubin, right? If there is any process which hampers with the flow of conjugated bilirubin in the common bile duct, this will lead to increase conjugated bilirubin, right? So this will lead to increase in conjugated bilirubin, right? So this is the concept of unconjugated and conjugated. So any pathology in liver which is preventing conjugation of bilirubin will increase unconjugated bilirubin, and that is seen in Gilbert syndromes. There is deficiency of an enzyme which is needed for conjugation, and that is, you can remember it as UGT, right? So this is Gilbert syndrome. And there is one more condition which can presents with unconjugated hyperbilirubinemia, and that is Crigler-Najjar syndrome, right? So just remember these two conditions for unconjugated type of excess of bilirubin, right? So that ends the medicine part. We will take a 15 minutes break, right? And then we will start with the surgery area, surgery questions, right? So just a short break and I'll be back. Chalo. See you. Okay, dear students, welcome back. So in this session, we will start with surgery questions, and the very first question, it was from a very important topic, but yes, the question was very difficult in presentation because a laparoscopic image was given, and yes, it's slightly difficult on the part of a student to read the laparoscopic images. So it arrow was shown and it was pointing towards some structure, and it was like for the students to identify what structure it is. Now this actually is related to the Callet's triangle, okay, and the structure which was pointed out, it was actually the cystic artery. So this is the cystic artery, right? This is the cystic artery. Now this structure is gallbladder, okay, so this is gallbladder, this is liver, and this one is the cystic duct, okay. So this area was actually the cystic artery. So it is again related to the Callet's triangle. So yes, little difficult for the students to decode the laparoscopic image, but yes, this is how we can just correlate it with the illustration. So here you can see this is the gallbladder, okay, so this is the gallbladder, okay, and this is the cystic duct, this is liver, this is right hepatic duct, this is left hepatic duct, this is the common hepatic duct, right? So this is the common hepatic duct and this is the cystic duct, and together it forms the common bile duct, right? So this is the common bile duct, clear? So this is the triangular area which is the Callet's triangle, right? So this is the triangular area, okay. And why this is so much discussed? Because of the presence of the cystic artery in that triangle, right? So this is the cystic artery and it is coming from the right hepatic artery, okay. So this cystic artery is very important here because there are chances of injury to this cystic artery while doing laparoscopic cholecystectomy, right? So therefore it is always discussed, and yes, this time they gave a laparoscopic image which I felt is quite difficult from the student point of view. So again, this is the image here. You can see this is the cystic artery here, okay. So this is the cystic artery, okay. Then this is the cystic duct, this is gallbladder, this is liver under surface, of course, right? So this is very important here, the cystic artery, right? So this was actually asked in the question. Then there was one more very difficult question, and I would say we have seen such a questions for the very first time in FMG, and that was about the location of the mesh which is used for ventral hernia repair. Now if you can see the mesh here, right, and before that you should know what is ventral hernia. Ventral hernia actually means if suppose if this is the anterior abdominal wall, right, on the inner side we have all, this is all intestines, okay. So this is anterior abdominal wall and this is all loops of intestine, right? So normally the anterior abdominal wall is strong enough to produce to avoid any sort of herniation, but suppose if there is any operative intervention and that makes that area a little weak, and sometimes the loop of intestine, suppose like this, the loop of intestine, they can herniate out of this, right? So this is your ventral hernia, right? So there is a defect through which there is herniation of bowel loops. And importantly, we see in cases of incisional hernia. So incisional hernia is a important example of ventral hernia, where if we have done laparotomy for any cause, the site of operation becomes a comparatively weak area as compared to the remaining anterior abdominal wall, right? So this is the ventral hernia. Now, whenever we are repairing this kind of hernia, so what we do, we will put the intestines back, and then we have to reinforce this potentially weaker area. So what we do for that, we put a mesh, right? So we put a mesh, and the location of placing this mesh can be different with respect to the rectus abdominis muscle, right? So with respect to the rectus abdominis muscle, there are different ways of placing this mesh, and then the nomenclature is also different. I think all of you know what is rectus abdominis muscle. That is the six-pack muscle of the abdomen, right? So many times what we do, we can put the mesh in front of the muscle. We can also put the mesh between the two muscles. So okay, so this is another rectus abdominis muscle of both the sides, right? So we can put the mesh between the two muscles, or we can put the mesh in the front of the muscle, right? Posteriorly, there is the rectus sheath, right? So you can see this is the rectus sheath, suppose, and even posterior we have the peritoneum. So this is the peritoneum. Clear? So we have this liberty to place the mesh somewhere here. So we can keep the mesh somewhere here below the muscle, but in front of the rectus sheath, or we can keep the mesh here behind the rectus sheath but in front of peritoneum, or we can keep the mesh behind the peritoneum. So we can keep the mesh anywhere, and based on the place of putting this mesh, we have got different nomenclature, right? So this was approximate image. I am very sure this won't be the exact image which was asked in the exam. Now this image has been taken just for discussion purpose, and I just want to discuss the basic concept so that maybe later on you could attempt such questions, right? So we can see this is all mesh. In simpler terms, mesh is net, right? In simpler terms. So this is how a mesh looks like. Okay, so this is the mesh, and we can place it anywhere. And now here I have kept one image also. Now this is peritoneum. Clear? This is the rectus abdominis muscle. Clear? Then this is the anterior rectus sheath, and this is the posterior rectus sheath. Clear? So these are few nomenclature which you should know, and the dotted line actually represents the placement of mesh. Now here the mesh is placed anterior to the muscle and the anterior rectus sheath. So this is known as the onlay variety. Okay, so this is onlay. Clear? Then here what we have done, we have placed the mesh in between the two rectus abdominis muscle, and this is known as inlay. Clear? So onlay over the surface of the muscle, or you can say anterior to the muscle, inlay in between the two muscles. Now let us look at the image and what we can see here. You can see this is skin, right? Then there is subcutaneous tissue, and if you can notice properly, right, you can see these are all muscle fibers. Okay. Similarly here you can see the muscles fibers. These are muscles fibers. On which muscle? I think most of you can say that this is the rectus abdominis muscle. Clear? So this is the rectus abdominis muscle, and hence it means that the mesh is placed deeper to the rectus abdominis muscle. And this is which type of mesh then? It is sublay, right? So what is sublay? You can see here the mesh is placed behind the rectus muscle. It can be in front of the peritoneum, behind the rectus sheath, or it can be behind the muscle in front of rectus, posterior rectus sheath. So this is sublay variety, right? So if you can see, if you can just see the muscle on the operated part, you can presume that the mesh is being placed deeper to the muscle. So any placement deeper to the muscle but in front of the peritoneum is sublay. And if the mesh is placed deep to the peritoneum, then it is intraperitoneal, right? So this is intraperitoneal mesh. Clear? So these are the different ways in which we can place the mesh, and the nomenclature is different according to the placement or the site of placement, right? So in this particular image, this mesh is below the rectus abdominis, so it is sublay type of mesh, right? So this is the concept of this mesh. Yes, it was a little difficult from student point of view, because I think very rarely we do attend these kind of advanced surgeries. Anyway, so this is the concept of mesh placement. Now there was a very easy question, and I think everyone must have marked it right. So what you can see here, now this is the upper limit of diaphragm, right? So you can see this is the diaphragm, and just below the diaphragm you can see this black shadow. This is all air, okay? So, and then this white is all liver, okay? So this is liver, and here we will have, this is all black shadow, that is actually gas, or what you call air. So this is a classical X-ray of air under diaphragm, which I think everyone knows. So this is air under diaphragm, and that is, I think everyone knows, that is pneumoperitoneum. And the moment you have this word pneumoperitoneum, I think there should be no confusion whatsoever that it is a case of gut perforation. So hollow viscous GIT or gut perforation, right? And the air which is liberated, it just ascends up, comes to lie underneath the diaphragm. So this is all air under diaphragm, right? So I think no more discussion needed for this. A classical case repeated n number of times. Now next question was about a skin graft which was shown, and student was supposed to identify what graft is this. Now if you look here, you can notice two things in this particular thing. You can see that there are multiple fenestrations, or what you call multiple openings, right? So you can see there are multiple openings which are made, right? And second thing, you can see that you can stretch it, right? So you can stretch it. So the second thing is stretchability. And now this stretchability is because of these multiple openings or multiple punctures which are being made to this type of skin graft. Now, this is a classical split thickness skin graft, which is known as Thiersch graft. Clear? So this is a Thiersch graft, and now actually when we harvest the graft, the skin is intact, then we make multiple openings into that, right? So we make these multiple punctures or openings into the skin graft, and there are two purposes of doing these multiple openings. One is of course stretchability. You can stretch it, and that way you can cover larger area, right, of wound where skin grafting is needed. Secondly, this multiple openings also gives way for any exudation from wound, right? So because we are keeping this graft over the wound, and if there is any exudation over the wound, from the wound, and if there is no area or there is no provision for inlet or the remove or drainage of that exudate, then it might displace the graft. So we make multiple openings so that exudate, it just comes out through these openings, and it does not displaces the graft from its position, right? So graft is not displaced, right? So this is split thickness skin graft. And in terms of skin anatomy, suppose if this is skin, this is all epidermis, below epidermis is dermis, and below that we have hypodermis, right? So this area is all epidermis, right? This is all epidermis, this part is dermis, and this area is hypodermis. So what actually we are taking out in split thickness, we take whole of epidermis, right, and some part of dermis. Okay, so this area is taken out in the form of graft. So entire epidermis plus some portion of dermis. So this is split thickness skin graft. Split thickness skin graft. Clear? So this is Thiersch graft or split thickness, and commonly we harvest it from the thigh. So because there we have a lot of space from where we can take out this graft, and you can see there is one Humphrey's knife which is used to harvest this split thickness skin graft. Anyway, now the next question was about an ulcer which was shown over the heel, right? So you can see this is an ulcer here, and this is a classical location of a diabetic ulcer, or what you call trophic ulcer or neuropathic ulcer, right? Sometimes you might have this word neuropathic ulcer. Clear? So this is a classical picture of trophic ulcer, neuropathic ulcer, or diabetic ulcer. Now, arterial ulcer, I think most of you must have read Berger's disease, or what we call thromboangiitis obliterans. In such cases, we can see an arterial ulcer, which usually is seen around the areas of toes. Venous ulcer is especially seen around ankle joint, and pressure ulcer is seen in long term bedridden patient, right? So those who are lying on bed since long, and if we don't do proper back care, so pressure points like sacrum, okay, so sacrum, or scapular area, or even heels, back of heel. So these are all places where we can find pressure ulcer, but this is classical for diabetic ulcer. And if you are discussing about pressure ulcer, this is the area for ulcer formation if the person is lying on bed, right? So just like arterial ulcer in cases of thromboangiitis obliterans involving the toes, pressure ulcers on the pressure points, venous ulcers around the ankle, and diabetic ulcers, as the name suggests, can be seen in diabetic. And the ulcer is so deep, at times we can see the underlying bone, and there might be sometimes inflammation of the bone as well, that is osteomyelitis. So these are common ulcers which we see in clinical practice. Now there was another question in which an image was given of the oral cavity, and it was asked like what is the condition and what investigation you would do. Now if you look at the image here, you can see a reddish patch here, right? You can see this is all reddish patch here, and this is actually erythroplakia. Clear? Erythroplakia. Now the word erythro itself suggests, erythro means redness, and since this is a pre-malignant entity, means later on it can convert into carcinoma, so we should go for biopsy. So the best answer would come out to be erythroplakia and biopsy, right? So erythro word is actually red, so you can see the redness all around. Now this erythroplakia has to be differentiated from leukoplakia, and leuko word is actually white. So leuko word is white. Again, this is a pre-malignant entity, but the risk of erythroplakia getting converted into carcinoma is far more than that of leukoplakia, right? So if you see here, this image is showing leukoplakia, right? So all these white patches in the oral cavity, this is leukoplakia, and erythroplakia is far more carrying the risk of converting into carcinoma as compared to the risk of leukoplakia converting into carcinoma, right? So visual identification is quite easy, whether it is erythroplakia or leukoplakia. Now at times leukoplakia can be confused with oral thrush, especially what we see in cases of HIV infection, but the lesions of oral thrush, they look somewhat like this, but they can be scrapped. Now this leukoplakia cannot be scrapped, so that is one clinical way of differentiating the two conditions. Now next question, again this is a very important topic, repeated many number of times. So after accident, patient developed subcutaneous emphysema, there was no air entry on one side, and the vitals were also unstable. So what you will do? Immediate. Now if you look here, there is no air entry and vitals are unstable, right? And especially after accident. This all is highly suggestive of the possibility of tension pneumothorax. Clear? And I think most of you must be knowing what tension pneumothorax is. So suppose if this is the pleural cavity and this is the lung within that, okay, so what happens in a case of tension pneumothorax? There is collection of air within the pleural cavity, right? And what happens to the lung tissue? It collapses, something like that. Okay, so there is all air, so this air is getting entry into the pleural space, but it doesn't get any space to move out. So what happens? It will indirectly presses upon the lung tissue and causes it to collapse. And once the lung tissue will collapse, there will be no air entry, right? So there is no air entry, and this also causes hypotension. So this is unstable vitals, right? So this is tension pneumothorax. And for tension pneumothorax, since it is a surgical emergency, you have to pass a wide bore needle. It can be passed in 5th intercostal space or in 2nd intercostal space. The purpose is to give a space for this air to come out of the thoracic, to come out of the pleural cavity, right? So we do a wide bore needle insertion. So wide bore means the lumen or the gauge is wider as compared to other needles, right? So this is tension pneumothorax, right? So air, once it comes inside the thoracic, into the pleural cavity, it just presses upon the lung tissue and cause it to collapse. Okay, so therefore the air entry reduces, and since it hampers with the heart physiology as well, so there is hypotension. And shortly we need to do a wide bore needle insertion either in 5th intercostal or 2nd intercostal space. Clear? So this is tension pneumothorax, a surgical emergency. And one more thing you can see on X-ray, that the trachea, it shifts to other side, right? So shift of trachea, this is better visualized on X-ray, right? So X-ray chest. So this is a very important topic, and everyone has to read it in detail and get the concepts right. Now there is one more question, and it was slightly confusing on the part of student, because it states that a patient had a dilated tortuous leg veins. So the moment patient read these words, they quickly jumped on to varicose veins without going for further keywords, right? So dilated tortuous, if you read this much, definitely you may mark it like varicose veins, but there was something more which was given in the question and was supposed to be addressed. There is a past history of trauma at the same region, and now more importantly, the patient was having pulsatile veins. Now this is very important, and this clue made the diagnosis as AV fistula, because pulsatile veins, suppose this is an artery, right? Then this is the surrounding vein, and then there was a fistulous communication, right? So this is the arteriovenous fistula. So what happens whenever the arterial blood, it goes into the vein? So whenever this arterial blood will go into the vein, since it will go with a pressure in a pulsatile manner, so it will cause the vein to pulsate. So this is the pulsating vein, right? So the moment you have this word pulsating vein, it means some artery is now connected to the vein, and the pulsation of the veins are actually the pulsations of the arterial blood which is coming from artery, because normally veins never pulsate. It is just because that arterial blood is coming with such a force in a pulsatile manner, and it is making the veins pulsate, right? So this was the main keyword to reach up to a diagnosis of AV fistula, right? So AV fistula. Now next question, post delivery lady had tenderness of the breast and high grade fever, right? So this is lactating lady, right? So this is lactating mother, and there is tenderness in the breast and high grade fever. It means there is severe infection. So in a lactating mother, there is high chances of breast abscess, right? So in a lactating mother, there are high chances of development of breast abscess, and therefore she will have a reddish tender breast with systemic signs of infection like high grade fever, sweating and all, right? So this is how breast abscess will look like. You can see there is yellowish area also, and this is classical breast abscess. Clear? So this is classical breast abscess. Now there is one more, a very new question, and although the topic was important, pilonidal sinus, but the question which was asked from it was very difficult from a student point of view, and it is, you know, extremely difficult. Now let us see what the question was and how we can get up to the answer. So the patient was a known case of pilonidal sinus, and for which he was operated, and Limburg rhombic flap was used. Now the question was like, this is which type of flap, right? So actually what we do, suppose this is the area of pilonidal sinus, right? So if you see here, this is the pilonidal sinus, okay? So this is pilonidal sinus. I think everyone knows what does pilo means. Pilo means hair, right? So this is a pilonidal sinus somewhere in the gluteal cleft. So what we need to do, we have to excise this pilonidal sinus. And how it can be excised? It can be excised by removing the entire skin in a rhomboid or rhombic shape, right? So this is actually, this is the term rhombic shape, something like this, and this includes, this is the area of pilonidal sinus. So we have to remove a rhombic skin, subcutaneous tissue, everything. Now what happens, once we are removing this much area, then obviously this will lead to a defect, and this defect has to be covered by skin graft. So you have to cover it by some graft, otherwise it will get infected. So what we do here, now since there is no skin coverage over here, so we will take the skin flap from the nearby area, right? So for that we will preoperatively we will do the marking that we have to take this much, we have to take the flap from here, and then we have to transpose it, right? So please notice the word, we have to transport it, we have to transpose it to the defect which has been created because of removal of that pilonidal sinus, right? So we have to preoperatively mark it. Now once we have removed the pathology along with the entire structure, so this, you can see here the defect has been created, and now we have to cover this defect. So what we will do, we will make a flap right? So in the normal skin, we will give like we will just give one incision like this, and we will give another incision like this, right? And we will not give any incision at the base, no incision here, right? So now this area will be dissected off the deeper tissue, and now this area will be, now it originally it was here, right? Originally it was here. Now it will be transposed to this vacant area, and it will be sutured here, right? So this is the new place of this skin which was originally here, and then this area will be sutured like this. Okay, so now it is sutured, right? So the flap has come to cover the defect, and the incision is closed everywhere, right? So this is the Limburg rhombic flap, and since we have simply changed the position of the flap like this, so it is known as transposition flap. Clear? So this is a classical transposition flap, right? So here you can see this was the defect. So this is the defect here. Now we are taking a flap from the surrounding skin, and we are simply just turning it like this, and we are suturing it over the defect. And at other place where we have given the from where we have taken the graft, that is sutured, although there might be some tension, but we will suture the defect as also, right? So this is the transposition flap. So Limburg rhombic flap for pilonidal sinus is a classical example of transposition flap. Clear? And then this is advancement. You are just removing the flap from the surrounding skin, and then you are moving it little up, so you are advancing it upward. So this is advancement flap, right? Then if the transposition flap is applied in a semicircular manner, it is known as rotation flap, right? So we are rotating it. So this is rotation flap. So these are all examples of local flaps, advancement, rotation, and transposition, right? So for pilonidal sinus, the the answer is transposition flap, right? So again, this is a very new question. I have seen it for the very first time, and I feel it was little difficult for the student also. Now, next question was again a very straightforward question. 4 weeks old child, recurrent episodes of non-bilious vomiting. X-ray was classically showing single bubble sign, right? So you can just see a single air shadow, right? So this is single bubble sign, and it means the obstruction is somewhere here. So this is a classical case of pyloric stenosis. Clear? I think everyone must have marked it right. And this is a classical case of pyloric stenosis. The presentation is very important at around the age of 1 month, when the obstruction is severe enough so as to lead to non-bilious vomiting. Non-bilious means without bile, and it is very obvious why there is no bile, because the obstruction is proximal to the opening of common bile duct. And what electrolyte abnormalities we see? Hypokalemic, hypochloremic, right? Metabolic alkalosis. So this is metabolic alkalosis. Clear? So I think there should be no confusion in this question. It's very important and a very easy question, right? Now, there was a question about a patient who is having swelling in the thyroid region, and most importantly, it moves with deglutition and protrusion of the tongue. There is rupture with some pus discharge also. Now this is a classical presentation of an infected thyroglossal cyst, because thyroglossal cyst, the two classical points are protrusion on swallowing movement, that is deglutition, and protrusion of the tongue, right? So this is movement with the swallowing movement and protrusion of the tongue. Clear? So these 2 points are very important, or very characteristic for making a diagnosis of thyroglossal cyst. Sometimes it can get infected, and then there might be pus discharge as well. Now clinically, one of the important problems with related to thyroglossal cyst is that later on it can get converted into papillary carcinoma of thyroid. So that is a problem with thyroglossal cyst. So we can have this higher risk of malignancy. So there may be development of papillary carcinoma thyroid. So this is, you can see a midline swelling, right? So this is midline swelling, and usually it is below the hyoid, right? So that is subhyoid, below the hyoid bone. So this is thyroglossal cyst. Okay, classical picture. Now this is again a very easy question. Most common cancer, females, India, is breast, right? So no discussion in that. Now most common incision for appendicectomy, again this is McBurney's incision, also known as the gridiron incision. So if you look here, this is the McBurney's incision, right? This is the McBurney's incision, which is also known as the gridiron incision. So this is the commonest area where we give incision to do appendicectomy. Clear? So this is most common incision employed for appendix. Now Cockers is usually for upper abdominal surgeries, right? So if you see, this is the Cockers incision. This is the Cockers incision, especially upper abdominal surgeries. Then this is midline incision for laparotomy, right? So whenever we are, like, you must have heard, like whenever there is pneumoperitoneum, we do laparotomy to search out for the site of perforation. So this is midline incision, and that is usually done for laparotomy, right? So anyway, for the gridiron incision or the McBurney's is the classical or the most commonly one which is used for appendectomy, right? So this is. Now next question was about indirect inguinal hernia surgery, and it was asked like which nerve can be injured if we are doing surgeries for indirect inguinal hernia. So now here you must know what is indirect inguinal, highlighting this particular area because that is the Hasselbalch's triangle. So this is the Hasselbalch's triangle. Now coming to the indirect inguinal hernia, the herniated content enters through the deep inguinal ring and comes out through the superficial inguinal ring. So this is deep, this is the indirect inguinal hernia. Now suppose if the herniated content enters through the Hasselbalch triangles and comes out through the superficial inguinal ring, this is the direct inguinal hernia, right? So this is the concept of indirect and direct inguinal hernia. Now what happens, there is one nerve which is entering through the deep inguinal ring like this. This is the ilioinguinal nerve, right? So whenever you are operating on indirect inguinal hernia, there are chances that you might injure ilioinguinal nerve, right? So that's why in indirect inguinal hernia surgery, there is possibility of injury to ilioinguinal nerve, which is entering through the deep inguinal ring. Clear? So this question we have already discussed in anatomy. So the presentation, I have changed the presentation. So just to give you more, ideas how which question can be framed in different terms. So while doing esophagoscopy, there was perforation of the esophagus around 25 centimeter from the central incisor. So we know that what structure is there at 25 centimeter in esophagus, compressing the esophagus at a distance of 25 centimeter from the central incisor, that is arch of aorta, right? So this is the arch of aorta, which is compressing the esophagus at a distance of 25 centimeter, right? So that finishes the surgery part, and after a break of 15 minutes, we will start with obs gynae, right? So there is 15 minutes break. So see you on the other side of the break. Thank you. Hello, dear students. Welcome back. We will start this session by obstetrics questions. So, one of the question was about puerperial pyrexia. Now, here, pyrexia word means fever, and puerperial is, of course, the postpartum period. So, that is puerperial pyrexia. Now, here you should remember one thing, that the word is puerperial, right? So, pyrexia is, of course, the fever. So, it doesn't mean that it is having only obstetrical causes, right? So there can be some non-obstetrical causes also which can lead to puerperial pyrexia, right? So anyway, the exact definition is that, of course, there is temperature. So the temperature is more than 38 degrees Celsius and the time duration is 24 hours after. This is very important, right? So more than 38 degrees Celsius after 24 hours of delivery, or what you can say 1 day of delivery. So this is puerperial pyrexia, a very straightforward question. And yes, it's like if you know the exact definition, right? So after first 24 hours, and then you can see the causes. It can be obstetrical, non-obstetrical, like chest, throat, breast, urinary tract, anywhere, right? So this is puerperial pyrexia. Now, the next question is again a very important question, and it has been repeated number of times. So ideal number of antenatal visits. So here there are two things. One is minimum and second is ideal. So these are actually antenatal visits. Antenatal visits. So there are two things, minimum, and this is again with respect to India or WHO. Now, India, the government of India says at least the lady should come 4 times, and WHO says 8 times. So these are the minimum antenatal visits. And when it comes to the ideal, it is nearly 10 to 14 visits, right? And how this is calculated, like we can divide the pregnancy, like first 7 months, 8th month. In first 7 months, she is supposed to come once a month, once per month, and therefore this will come out to be 7 visits. In 8th month, she should come twice a month. This will count for 2 visits in the 8th month, and in the 9th month she should come once per week. Right? So that will be again like 4. Right? So if you just add it up, it will come out to be 13, right? So right answer would be 12 to 14. So I think most of you must be knowing this, not a new concept. So this is the antenatal visits concept, clear? And if we talk about the 4 antenatal visits, which are the minimum recommended by the government of India. So minimum in India, here 1, 2, 3, 4. So the first visit has to be made as soon as possible, like after the confirmation of the pregnancy. So as soon as possible after confirmation of pregnancy, clear? And that may be around within, as soon as the pregnancy is confirmed. Then the second visit has to be between 13 to 26. Then the third has to be between 27 to 34 weeks. And the fourth visit should be between 35 weeks till. So this is how we can divide the number of visits at least once in this time frame. So that comes out to be 4 visits at least, around 12 week, 13 to 26, then 27, 34, and finally. Now the next question was about outlet forceps, and there were few options, and which one is the most ideal situation for application of outlet forceps. Now if you look at the word proper, outlet, so whenever the fetal head is on perineum, we apply an outlet forceps, right? And here you must be getting some terms like station 0, station +2, right? So now what do you mean by the word station here? So station of fetal head. And here we take the station as 0 when the fetal head is at the level of ischial spines. Clear? So at the level of ischial spines, we will give it a value of 0, and then +1 is like 1 centimeter, +2 is like 2 centimeter from this position downward. So as the fetal head will keep on coming downward towards the introitus, we will use +1, +2, like that. And if the fetal head is above the level of ischial spines, we will use -1, -2, and these are actually the distance in centimeters, right? So this is how we define the station of fetal head. So if you look in the image, these are the ischial spines, right? So these are the ischial spines. Okay, these are the ischial spines, and if the fetal head is at the level of ischial spines, we will say that the fetal head station is 0, and that is fetal head is mid pelvis, right? Now when the fetal head comes somewhere around the introitus, and that is, in simpler words, that is known as in or at the perineum, and the scalp is visible through the introitus, right? And this is an ideal scenario for application of outlet forceps, right? So for outlet forceps, the fetal head is at the perineum, splitting the labia, and it is seen through the coming out through the introitus, right? So this is the perfect condition for application of outlet forceps. Okay? So this is for outlet forceps, head on perineum. Next question. Then I think this is again a very basic question and a repeat which has been asked over the years. So exclusive breastfeeding, it should be continued till 6 months. So exclusive means only breastfeed, right? Nothing else. And then, although we can continue the breastfeeding till 2 years, but then it is not exclusive. We can give additional supplements also, right? So this is exclusive till 6 months, and we can continue breastfeeding till the age of 2 years, supplementing some feeds with breast milk. Not much to discuss in this question. Now, marker for ectopic pregnancy. I think this is again a very easy question, and everyone can mark it right. That is beta human chorionic gonadotropin, and this is a ultrasound of a normal pregnancy. You can see the gestational sac within the uterus, but on this is ectopic Here the ectopic pregnancy is actually within the cervix. So uterine area is all empty. This is empty uterus. So classical ultrasonographic image of ectopic pregnancy. Right? Now, this question is good. Early cord clamping. And this is done in case of Rh negative mother, because we just want to minimize the transfusion of the blood from mother to fetus. So early cord clamping, that is done for Rh negative mother, right? So can also be done in asphyxia or a diabetic mother also. But more importantly, this is Rh incompatibility. Now, next question was about ventouse, which is also known as vacuum delivery. So metal cup is applied to the fetal scalp, and then that, because of that suction, it remains attached, and then we can apply the traction. So that is vacuum delivery, and this should not be done for a preterm child. So never should not be done in a preterm fetus, right? So this is, and this is the, you can see the cup, and some, and there is formation of chignon, right? So this is known as chignon. That is the point where the cup was placed on the fetal scalp, right? So this is ventouse or vacuum assisted delivery. Now this is important. A 17 weeks pregnant lady, and when we measured blood pressure, it was 144/94. And there is some modification in this question as well. This is first reading, right? And then she was allowed to take test, and after 4 hours we took second reading, right? Took second reading, and the second reading was also like 144/94, right? So there were 2 readings which were done at some time, and both the values were high. It means there is hypertension. Now, this was not associated with any proteinuria. So there was no proteins coming out in the urine. So such a presentation is known as chronic hypertension, right? So the time period is 17 weeks. It means a pregnant lady, a hypertensive lady has become pregnant. Because for gestational hypertension, hypertension will develop after 20 weeks of gestation. Clear? But there will be no, but this is important that there is no, this is important that the period of detection of this hypertension is after 20 weeks, right? So this is gestational hypertension. Now, if such a lady develops proteinuria, then you will call it preeclampsia, right? Hypertension after 20 weeks plus proteinuria, that is preeclampsia. Hypertension after 20 weeks without proteinuria, that is gestational hypertension. And hypertension before 20 weeks, chronic hypertension. Here, so these are the 3 terms which are discussed in hypertensive disorders of pregnancy, right? And here the classical case is like we have to take 2 readings, some gap. Why? Because first reading might be high because of anxiety, right? First reading might be, little raised because of anxiety. So let that lady calm down, and after some time take the blood pressure again. If it still remains elevated, and the cutoff is actually 140/90 millimeter of mercury. So any value more than that, so this is the cutoff actually. Any value more than 140/90 has to be taken as hypertension, and it all depends on the time frame when you have detected hypertension, right? So chronic is before 20 weeks, and gestational is after 20 weeks, okay? And preeclampsia, hypertension plus proteinuria, okay? So this is very important, right? So this is chronic hypertension. Now, the next thing is that during labor, the head of the baby was delivered, but the shoulder was stuck. Head has come out, but the shoulder is stuck. Now, what is this known as? This is known as the shoulder dystocia. So if you look here, this is this area is pubic symphysis. Okay, this is pubic symphysis, and the head is out of the introitus, but the shoulder is impacted. So the anterior shoulder is impacted behind the pubic symphysis. So this is known as shoulder. Clear? So now, if this kind of picture is there, labor will not progress. Now what we need to do? We have to disengage this anterior shoulder from behind the pubic symphysis. So what we will do? We will tell the lady to flex both the lower limbs, flexion and slightly abduction. So that way it will open up the pathway, and then we give suprapubic pressure. We will try to disengage this anterior shoulder which is stuck behind the pubic symphysis. So we will give suprapubic pressure, right? So first is flexion and abduction at the hip joint and flexion of the knee joint, and second is suprapubic pressure to disengage the anterior shoulder from behind the pubic symphysis. And this technique is known as Mack-Roberts maneuver, right? So this is for shoulder dystocia. Now next question, a lady has breech presentation and has labor pains, right? So now what facilities you should keep ready in rare case if there is any indication for that, and that is actually emergency cesarean facility. So we can go for the trial of normal vaginal delivery, and there is mechanism of delivery in breech presentations, but there is possibility that that mechanism won't work, and then we have to switch on to the cesarean section. So in cases of breech presentation, be prepared for a cesarean section in case, right? So we should be ready with all the facilities for a cesarean section. So now this is the breech presentation, and we discuss usually three types. One is frank, and in frank breech you can see that the legs are extended, right? So the legs are extended, or you can say the lower limb is extended. Then the second one is, here you can see that the legs are flexed, or the lower limbs are flexed. So this is complete breech. So legs are flexed. Okay. So extended is frank and flexed is complete breech. And third is that if you can see that the leg is almost coming out through the introitus, so that is known as footling breech, right? So there is extension at the hip joint, right? So these are the three types: frank, complete. Be ready for emergency cesarean section in case the labor doesn't progress as per the expectation. Now next question, there was a lady who presented with vaginal bleeding at 10 weeks of gestation, and on ultrasonography we saw multiple cystic spaces fetus was not there, and beta HCG level was extremely elevated. Now, what should be done? Now, firstly, we have to reach up to a diagnosis here. Then only we can think of what should be done here. So, if you see, there is bleeding in early pregnancy, right? There are multiple cystic spaces. There is no fetus as such. Beta HCG levels are extremely high. This all goes in favor of molar. Yeah. So this defines a H mole pregnancy, and these multiple cystic spaces actually gives no storm appearance. Yeah, so this is no storm appearance, and I think it's not difficult to make a diagnosis of H mole. And for this, what we do, we will do suction, evacuation, and follow-up has to be done with beta HCG levels. Clear? This is the management plan for molar pregnancy, right? So you can see here, you can see so many cystic spaces. Okay, so many cystic spaces. This is classical appearance of molar. Right? So this is molar pregnancy, and this is how we do suction evacuation. Next question. Pregnant lady presented with 32 weeks gestation, and there is abdominal pain, vaginal bleeding. Uterus is tender, and fetal movements are not perceived. What is the diagnosis? Now here, important word is that bleeding in late pregnancy, and there is severe abdominal pain. This is a case of antepartum hemorrhage. Okay, antepartum hemorrhage, and uterus is very tender. And the moment you have this kind of presentation, you have to answer abruptio placentae or accidental hemorrhage, right? So this is abruptio placentae. Now, abruptio placentae or placental abruption. Now, what happens here? The placenta which was attached to the uterus, it gets detached, right? So I show you an image. Look here. This is the normal attachment of placenta, right? But what is happening here? The placenta has detached. This is known as placental abruption, and this is all bleeding, right? So this is abruptio placentae, and the classical word is tender uterus. This is very important here, and this is one point based on which we can differentiate this from. So this is abruptio placentae, and the another condition is placenta previa, right? This is painful, this is painless. If you find these words in the clinical history, you can decide accordingly. Now, a young lady who is married is having abnormal vaginal spotting. You can say intermenstrual, right? So what you need to do first in such a case? Now, she is a married lady, and she is having vaginal spotting or vaginal bleeding. So what can be a possibility here? That there might be a pregnancy, right, which was not confirmed, and it had gone into abortion, right? So this could be a case. So what you will do? Firstly, check whether she was really pregnant or not. Then only think of any other possibility, because she is a young married lady, so there is high possibility that she might be pregnant. And then there might be abortion, which usually presents as slight bleeding, right? So you see there is one threatened abortion where the process of abortion has started, but the cervical os is closed and the fetal activity is present, right? But threatened then will progress to inevitable. Inevitable means unavoidable. Once this comes, it means abortion cannot be stopped. In threatened, we can stop the process of abortion by giving bed rest plus on. Here we can try, but once it has moved into inevitable, it means now the termination or the abortion cannot be stopped. So here again the cervical will open up, and this is just because the fetal parts are descending down, and of course there will be bleeding per vagina, and here usually fetal activity is absent. So all further stages fetal activity is usually absent, right? And then there is incomplete. It means os will remain open, the fetus is expelled. Then complete, the os will close, right? And there is no fetus inside the uterus. Missed, it means the abortion has already been there, so there is no fetal cardiac, right? So there is no signs of fetal life. Os remains closed. This is also closed here. Clear? So these are the different types of abortion which presents as per vaginal bleed. So if you see a young married lady with vaginal bleeding, think of abortion first, and therefore start with urinary pregnancy test. If it comes out to be negative, then evaluate for other conditions. Right? This is one thing. Now, next question. A lady was in labor and the fetus is in occipito-posterior position. Right? Now, there is a previous history of cesarean section. There already has been delivered a baby by cesarean section. Now, what should be done in such a case? In occipito-posterior position, right? So this is actually position. So here, if she is coming for the first time, we will always try for normal vaginal delivery. If this doesn't work, then we will go for cesarean section. Now, if such a lady again becomes pregnant, then she should be delivered by cesarean section. So there is no trial of normal vaginal delivery, right? So if in this case there is already a previous history of cesarean section, so better go with cesarean section. If it would have been a first case with occipito-posterior, then we can go for the normal vaginal delivery. But if already she had a past history of cesarean section for delivery of occipito-posterior, then straight away go for cesarean section. Now, we'll take questions of gynecology. So, as per FIGO, what is the definition of abnormal uterine bleeding? This is actually normal uterine bleeding. Right? So this is as per FIGO. Now here, the length of menstrual cycle, what is usually being taught, is like 28 days plus minus 7 days, right? So if a lady has the length of the cycle is between 21 to 35 days, then this is, so This is the usual teaching. But Ego says that if the cell cycle is more than 38 days, then it should be included in abnormal uterine bleeding, right? So here we don't take this 35 days criteria. The criteria here is 38 days, right? So this is as per FIGO. So any bleeding more than 38 days is infrequent menstrual cycles or abnormal uterine bleeding, right? So this is FIGO abnormal uterine bleeding system. So the frequency of menstruation is occurring more than 38 days. So this is abnormal uterine bleeding as per. Now, this is one more very important question, and it has been repeated number of times about the effect of inhibin. Now here, anterior pituitary, then females, it will act on granulosa cells of ovary. So from here, there is FSH actually, which will promote release of inhibin. FSH is promoting the release of inhibin, but inhibin is inhibiting the release of FSH from anterior pituitary, right? So inhibin, the action is inhibits FSH release from anterior pituitary. So I think there is no much discussion for this very straightforward concept. Okay. Now there was one question about tandem radiotherapy. Now this tandem radiotherapy is actually used for carcinoma of cervix, and this is a form of actually brachytherapy. More importantly, this is intracavitary brachytherapy. Now we know that brachytherapy is a form of radiotherapy in which source of radiation is placed close to tumor. Clear? So this is brachytherapy, and this form is actually intracavitary, where we place the tandem within the uterine cavity. Right? So this is the tandem here, and it goes within the uterine cavity. There are two ovoids as well. So these are the ovoids which are placed in the fornices. So these are fornices, right? So this is the appearance. This is the tandem here, and these are the ovoids in the vaginal fornices. So this is a form of brachytherapy for carcinoma. Tandem radiotherapy. Then one question, this is again very important topic, like Bartholin gland, Bartholin duct, or Bartholin abscess. So many times we have question from this segment. Now, what is the location of Bartholin duct? Now, this is actually, if you say this is anterior 2/3, and this is posterior. This is the point of opening of the Bartholin duct in the labia minora and the hymen. Right? This is the Bartholin duct opening. So if you see here, this is the Bartholin gland, which actually secretes a fluid, Bartholin duct. And if you see, this is anterior, this is the posterior 1/3. So junction of anterior 2/3 and posterior 1/3, and this is all is minora, okay? And deep to labia minora is hymen. This hymen. right? So at the junction of labia minora with hymen. This is Bartholin. Now, MTP, medical termination of pregnancy in a contraceptive failure. It means if a lady is on OCP or some other mode of contraception, and if she gets pregnant, up to what time we can do medical termination of pregnancy? This is 20 weeks. That is the usual accepted time, 20 weeks. 24 weeks, that is if the pregnancy has been resulted because of rape, and even longer if there are fetal, right? So we can look for MTP even after 24 weeks if there are fetal abnormalities, right? So 20 weeks for OCP failures. So failure of contraception up to 20 weeks. Now this question is good. Early postpartum copper T, or you can say IUCD. Now there is actually a slight variation in the terms which are used in relation to postpartum IUCD, right? So one term is post placental, and this is when the IUCD is given within 10 minutes of delivery, right? So that is the immediate postpartum, and this is also known as post. This is immediate or post placental. Then, if we can wait, if we can do it up to 48 minutes, that that is known as early postpartum. So, from 10 minutes till 48 hours, this is early postpartum. And if we do it after 6 weeks of delivery, that is known as interval IUCD insertion. And this is advocated because this is preferred because there are less chances of IUCD expulsion. So this is preferred interval 6 weeks after delivery. Just remember these 3 words. One is post placental, which is also known as immediate postpartum. So also we can just take the timeline like delivery and 10 minutes. This is immediate. Then if we go up to 48 hours, this is early. Even if we go longer, after 6 weeks, interval IUCD insertion. Clear? So this is in terms of the time frame. So in this question, the question is about interval. So that is between 10 minutes. It's about early postpartum. So that is between 10 minutes to 48 hours after delivery. So that is how we use this nomenclature. Now, next question, again, a very important and has been repeated many number of times. This is post-coital contraception, which is also known as emergency contraception. Okay. And preferred agent is levonorgestrel, which is given as 0.75 mg, then 0.75 mg, and there has to be a gap of 12. This has to be given within unprotected act. Right? So this is one way, or we can directly give 1.5 mg stat. So there are 2 ways in which we can give LNG as a vital contraceptive, levonorgestrel. Now this is a Lippes loop, which is inert intrauterine contraceptive device. You see the typical double S shaped appearance. This is double S shaped, right? So this is double S shape. This is Lippes loop. This is non-medicated, or you can say first generation IUCD. Non-medicated or first generation IUCD nowadays not in use anymore because we have availability of better options. Now, a young lady presented with intermenstrual spotting within first month of IUCD. Now this word is very important. First month of IUCD insertion. There was no other complaints. Now what should be done? Now remember, it is very common IUCD insertion till 3 months. Lady can have bleeding, right? So this is normal phenomena after IUCD insertion, and therefore you should tell the lady, don't worry, this is common. Once we have inserted IUCD, this is supposed to happen. So don't worry about this bleeding till a period of 3 months, right? So reassure. All you can do, you can give some iron just to compensate for that blood loss, right? So no need to do anything within the first month, because till 3 months we need not worry at all. Now, a lady has irregular menstrual cycle. There is hirsutism and acne, and she is also having problem in getting pregnant. There is acanthosis nigricans, serum testosterone levels are high, and there is insulin resistance. And then USG is shown, which is showing typically so many follicles that is just giving a necklace kind of appearance, right? Necklace kind of appearance. So this is necklace appearance. So a very classical presentation for polycystic ovarian disease, and here you can see here and syndrome. Now H is hyperandrogenism, IR is insulin resistance, and AN is for acanthosis nigricans. So a classical PCOD case. Now, procedure of choice for a nulliparous woman who is having uterine prolapse but without cystocele, right? So classical patient for sling operation, right? So there is uterine prolapse in a nulliparous. Nulliparous means, or you can say nulligravida. She has not been pregnant any time. That is nulligravida. Nulliparous means the pregnancy has not. Even if she is pregnant anytime, the pregnancy has never crossed the 28 weeks mark, right? So in such a case, we should go for sling operation or cervicopexy. That is Shirotkar's operation. This is typically for nulliparous lady. Then there was one more question about the same entity, and there was a lady who is having something coming out through the vagina, and then there is pelvic pressure, discomfort, and she have several deliveries. So this is a classical case of uterine prolapse, right? So you can see this is uterine prolapse, and especially in this particular image you can also see the development of decubitus ulcers. Okay, so this is known as decubitus ulcers. right? So this is in such an elderly lady, it's better you just do hysterectomy. These are the different grades of uterine prolapse. In stage 1, it reaches to the cervix part, it reaches up to the half of vagina. In stage 2, it reaches up to the introitus. In stage 3, it is out of the introitus, and in stage 4, the entire uterus is out of the introitus. So that is the grades of prolapse, right? So this ends the obstetrics and gynecologic part. Again, we can take a 15 minutes break, and then we will take the last subject for today, and that is ESL, right? So we'll take a 15 minutes break, and then we will start with the last chapter for today's session. So see you on the other side of the break. Welcome back, dear students. In this session, we will take PSM, right? So the very first question was about urban PHC, right? So this is urban PHC, and that caters to the population of 50,000, right? So there are, in relation to PHC, we discussed two more things like rural or hilly area. In rural, it is 30,000, and hilly areas, it covers a population of 20,000, right? Urban covers a population of 50,000. Yeah. Now, related to TB, there is a web portal in India, and that is known as Nikshay. Right? So this is Nikshay, and should not be confused with Nikusht, that is related to leprosy, and Nikshay, which is related to this is actually a pregnancy kit. Clear? So TB related web portal, that is Nikshay. And DOTS 99, that is actually online monitoring of RNTCP by the RNTCP staff, whether the patient is adhering to the treatment protocol or not, right? So that is 99 knots, again for treatment of tuberculosis. So Nikshay is web-based portal for tuberculosis, and Nikusht is web-based portal for leprosy. Nikshay is home-based pregnancy test kit. Now, this is, again, we have already discussed, this is a classical Lippes loop, which is a first generation intrauterine contraceptive device. Then ideal antenatal visits. Now, this is important. Already discussed about this. So whenever it comes to ideal, you have to mark 12 to 14. So we have already discussed this. Now, there was one question about what is that practice of instilling a particular point of view in people's mind and inhibiting their independent thoughts. So this is a passive, thought which is being to the students or taught to the general public, and they don't apply their knowledge to say whether that is right or wrong. Whatever is given passively, they simply accept that. So that is known as health propaganda, right? And this differs from health education, in which the subject is actively thinking about the concepts, whether they are right or wrong. So health propaganda, the knowledge is instilled passively or without evoking their thought response, right? But health education, these are acquired by the population, and people, they think, they apply their knowledge, right? So this is health education and health propaganda. Then this is again a repeat question. Females cancer, India, this is breast cancer. Okay. Now, a very straightforward question about what percentage of data falls within one standard deviation, right? One standard deviation is 68.1 standard deviation and 34.1% on either side. So the total comes out to be 68.2. So one standard deviation. Now, the vector which is responsible for transmitting Orencia or Rickettsia shushugamushi, and this is trombiculate mite. Trombiculate. This condition is actually scrub type. This is scrub typhus caused by Rickettsia or Orencia shushugamushi, and mite is the vector. There is one more entity, that is epidemic typhus, and that is caused by Rickettsia prowazekii, and that is transmitted by louse. There is another entity, that is endemic typhus, which is caused by Rickettsia typhi, and that is transmitted by flea, right? So these are few conditions, rickettsial condition, which starts with the word typhus, involves the word typhus. Scrub typhus, epidemic typhus, and endemic typhus. Now, there was one question about the level of fluoride which causes crippling fluorosis. Depending on the increase in concentration of fluoride, there is the sequence of terms. There is mental, then there is mental, value increases, there is crippling fluorosis, right? So this is increasing fluoride. Crippling is observed when the levels are more than 10 milligram per deciliter. So dental, if the levels are between 1.5 to 3, skeletal when the levels are between, and crippling when the levels are more than 10 milligram per deciliter. Now, there was one question about the sustainable development goals. The target was 2030, and it was about the target values for MMR as well as under 5 mortality rate. So MMR under 5 mortality. So actually there are three things. One is MMR, another is under 5 mortality rate, and the third one is the neonatal mortality rate. So that is NMR, right? So the third one is NMR, and the MMR has to be, the target is to reduce it below 70, right? The target has to reduce it below 70. For under 5 mortality, the target is to reduce it below 25, and for NMR, the target is to reduce it below 12, right? This is less than 70, this is less than 25, and this is less than 12 as per SDG 2030 target, right? So answer comes out to be E, 70 per thousand per lakh live births for MMR and 25 per thousand live births for under 5 model. Okay. And the next question was extremely easy. It was like exposure to cotton dust, and I think everyone can answer this. This is by cyanosis. Trichosis is because of silica, and trichosis this is because of coal dust, and bagasosis this is because of cyanosis. Just a repeat question. Exclusive breastfeeding, the answer has to be 6 months. Now, there was a question about Anemia Mukt Bharat program, right? So, this is Anemia Mukt Bharat program, and here the iron folic acid supplementation is given. Now, what is the protocol to give this, right? So, here if you say pregnancy, lactation, right? So 6 months, okay, and reverse direction 6 months. Here, so later 6 months of pregnancy and first 6 months of lactation. During this period, iron folic acid supplementation has to be. So the better answer comes out to be in trimester of pregnancy and continue during lactation up to 6 months. Okay, so this is Anemia Mukt Bharat plan. Folic acid deficiency, I think everyone knows that it causes neural tube defects, which can be like anencephaly, myelocele, meningocele, or meningomyelocele, right? So this is all entities which are discussed under neural tube. Now, WHO definition of blindness. This is again repeated questions. It has been asked many number of times. If the visual acuity is less than, right? So if the visual acuity is less than 3/60, despite WHO definition of blindness, right? So visual acuity less than 3/60. Now, as per Factories Act, per capita space is 500 cubic feet, right? So this is just a straightforward one-liner. 500 cubic feet space for each worker. Now, heart of activated sludge process. This is also a straightforward. It is aeration tank in which there is the microorganism which out the oxidation process, right? Now, wasting in a child. Wasting is an indicator of acute, that is weight for height. Weight for height. So wasting is weight for height. And stunting is chronic, that is height for age. Stunting, and it is an indicator of chronic malnutrition. Clear? There are two terms, wasting and stunting. Now, question is like a gym. Notice that people who drink iced tea while exercising reduce more weight. Now, what type of relationship is this? Now, here, one is, third is iced tea, and now we all know that if someone will do exercise, its weight will. This is direct association. Two things are directly associated. Now, in this particular scenario, iced tea has nothing to do with weight loss actually, right? But since the person is also doing exercise, so this exercise is ideally decreasing the weight, but since he is also taking the iced tea, so many people think the gym owner is thinking that iced tea is leading to weight loss. So this is indirect association. Clear? This is indirect association, and this is the confounding factor. Clear? So this is indirect association. Then, very commonly asked question: a lady developed edema, visual disturbances, and heart failure after consuming a food item. So what kind of adulteration is this? Right. So the clinical case is suggestive of epidemic. The moment you find heart failure, edema or heart failure, this is epidemic dropsy, and here there is adulteration of curd oil with arginine oil. This arginine oil contains sanguinary. Clear? So the answer will come out to be, here you can see the classical pitting edema. This is epidemic. Now, there was a question about calculation of neonatal mortality rate. This is neonatal mortality rate. And before that, we should know what is neonatal period. Neonatal period, there are two components: early is first 7 days of life, and late is 7 to 28 days of life, right? neonatal period is 0 to 28 days of life as such, right? So if you just add these two, you'll get the neonatal period. Now, while calculating neonatal mortality rate, what you have to do? You have to check the numerator, that is the neonatal deaths is between 0 to 28 days, and the denominator is total live births, right? So neonatal deaths upon total live birth. Now, in this given question, they have given total birth, and total birth is actually live birth plus. So now we want to get the total live birth. So what we'll do, we will exclude the stillbirths. So out of this total births, we'll exclude the number of stillbirths, that is 50. What we will get? We will get the total live births. So these are the live births, right? Now we will applying particular concept. 50 neonates die within first 7 days, right? So this is 50, and this is 150, right? So this is 150. So this is actually 50 plus 150, that is equal to 200, and this is 4000. So if you apply here 200 upon 4000 into 100, you will get the answer as 50. Now you apply that concept, right? So this is the 50 is the NMR. So this is how you will calculate NMR. All you need to do is number of neonatal deaths. If it is given early or late, just add them up, and you have to get the denominator, that is total number of live births. Clear? So NMR calculation will be done like this. Now, next question was about morbidity of a disease is increasing. Now here, two terms, prevalence and incidence. Incidence is, prevalence is new cases plus old cases. So if morbidity is more, it means old cases will be, what will happen? New cases will come as it is, but old cases are increasing. It means prevalence will also keep on increasing. The answer would be, now this we have already discussed, IUCD, insertion and bleeding after 1 month, no need to do much, reassurance and iron tablets, because this is common occurrence after IUCD insertion. Now, next question. One of the member of the family is 68, another is 59, then 30, 27 and 5. So here, if you take the family chart, so there is a child, mother, 30, then grandmother, 59, and grandmother, 68. Right? And what we are supposed to do? We are supposed to calculate the dependency ratio. So this is actually dependency ratio. So in dependency ratio, we have to count how many people are elderly dependence, right? And then another concept is about younger, that is children's less than 14 years of age, right? So if we add these two, it will get the total 1065 or less than 14, right? And the denominator will be the remaining persons. So denominator will be 14 to 60. This is denominator. If we apply this concept to this question, now let us check the number of elderly dependents. There is only one elderly dependent, and that is grandfather, right? So this is in this question. Then let us see the younger dependent, and again that is only one. Total come out to be, okay, 1 and 1, that is 2. Now the remainings are in the denominator, that is 1, 2, 3. So the denominator will come out to be 3. So 2 upon 3 into 100, the answer would come out to be 66.6%. So this is how we can calculate the dependency ratio. More than 65, less than 14 are the dependents, and the remaining will be the denominator. Now, penicillin in rheumatic heart disease is which level of prevention? So, you know that if someone is having rheumatic fever, we have to give injection benzathine penicillin, right? So this is secondary prophylaxis, and most of you must know that if we are using the word prophylaxis, this is primary level of prevention. Clear? Prophylaxis is primary level of prevention. So the answer will come out to be primary level. Don't mix up this word secondary. Don't think secondary will be secondary. Don't think so, right? So that is wrong approach. So this is secondary prophylaxis, and prophylaxis is always primary level of prevention, right? So this is how question was slightly confusing, but if someone has applied the concept with a stable mind, he would have definitely got the answer. So that is the end of session, right? So I thank all of you for joining me. Very shortly I'll come with another session of the remaining subjects. So thank you everyone. God bless you. See you soon. Bye bye.